All right, good morning, and thank you everybody for joining our Social Need and Health Equity Summit. Everyone is on mute and will be throughout our webinar. Please put any questions into the Q&A and any technical issues into the chat. We are recording today's summit and we will send the link to the summit and a copy of all the slides to participants after the event today. I am Ginny Weir. I'm CEO of the Foundation for Healthcare Quality, and I am more than lucky to have been able to work with Locke, who has really spearheaded this initiative, and of course to Emily Robson and Kerry, who make up our BRIE collaborative team. A big thank you to the Washington Health Forum and One Healthport for their investment in our developing this common community standard. And of course, a thank you to our many volunteer partners who have helped us develop and grow our healthcare ecosystem's capabilities to really meet the needs of everybody across Washington and beyond. We convened the first iteration of this work in 2020, 2021, and again, over the next 2 years, we're able to do deeper dives with our workgroup members into screening, interventions, storing and sharing data, and advancing equity. I also want to acknowledge that we are speaking from the unceded land of the Duwamish people. We acknowledge them, past, future, and present, who have cultivated the land within Washington state, their knowledge and practices that support the health of the people, animals, plants, and land in our area. So today we really seek to build off of the CDC and others' definition of health equity, where every person has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this because of their social position or other socially determined circumstances. The foundation has been part of our Washington state health ecosystem since the late 1980s. We began as an organization tasked with an independent review of community health information and have really grown to become a trusted, neutral space for those who want to work beyond our siloed systems and sectors to improve delivery of healthcare for everyone in our region. And so our mission at the foundation is to catalyze quality improvement by bringing together those who typically do not talk to one another. And our framework for impact is based in clinical data, consensus building, feedback cycles, and evidence-informed practice balanced with promising practice. Our 4 care outcomes assessment programs convene communities of healthcare professionals dedicated to improving quality based on what our community can see in actionable chart abstracted data for cardiac, obstetric, general surgery, and spine surgery, as well as our newly developed community birth data registry, the public-private BRIE collaborative, the Washington Patient Safety Coalition, and smooth transitions. We are seeing increasing regulatory pressure for integrating social need into clinical care, including from Joint Commission and CQA. And just last week, the Center for Medicare and Medicaid Innovation announced their Making Care primary model, with Washington selected as one of the first states. This model includes several components designed to improve health equity, including requiring participants to develop a strategic plan for how they will identify disparities and reduce disparities, and then requiring participants to implement health-related social needs screening and referrals. Our work, sponsored by the Forum and One Healthport, really gives our state a leg up to meet this new charge. Parallel to this initiative to develop a community standard for assessing and addressing social need and aligning our healthcare system around equity, our foundation, in partnership with the Washington Health Alliance and Co-Imagine Health, has held a webinar series on health equity. Just this last month, we held a webinar examining the complexities of race, ethnicity, and language data, and I encourage everyone to look for that recording on our YouTube channel. Today, Nick will be leading us through our community standards in 4 parts, starting with an outline of our guidelines and then working into real-world examples from our guest speakers, including on screening and interventions, storing and sharing data, and then advancing equity. After a short break, we will reconvene to discuss making the case for change, return on investment, and our regulatory environment, and then a session on connecting to community, accountable communities of health and public health, and really their role in this work. And we will end today with our team member, Emily Robson, talking through our next implementation steps. And now I will hand it over to Nick.
Yeah, thank you for that introduction, Ginny. Good morning, everyone. As Ginny mentioned, my name is Nick Locke. I use he, him pronouns, and I'm the Director of Research and Best Practice at the Foundation. And it's really been my privilege to work with our work groups and in our community conversations around social need and health equity from our initial phase of this work in 2020 all the way to as we work towards wrapping up this phase by the end of 2023. And I'm also really excited to be able to present this event today. I will sort of be our MC for the event, walking us through each of the sessions, helping facilitate Q&A, and then sharing a little bit about what we've found through our work group conversations at the Foundation. As Ginny mentioned, this is today's agenda. We're going to be working through these 3 areas: social needs screening and interventions, storing and sharing data, and advancing equity. I'll be sharing some of the recommendations and best practices that we've found through our work at the Foundation, and then inviting up some of our partners from around Washington State to talk about what this work looks like in action at their sites. When we return from our content break, we'll be able to spend a little bit more time on alignment and creating sustainable action as we talk about making the case for change and how to connect to community. Real quick, I wanted to level set about the importance of social need and health equity. I'm certain for those of you who signed up for this event, you are aware of the impact of social need, but I just wanted to highlight that the World Health Organization defines social determinants of health as the conditions in which we live, work, and play. And the Robert Wood Johnson Foundation, through the County Health Rankings model, found that these social determinants contribute 40% to our overall health and length of life, which is about twice that of clinical care. We also know that the experience of racism, implicit bias, and discrimination contributes to health inequities across different clinical services. So I think we've seen growing awareness about the role of social need and health equity on outcomes and across our state as well as across our nation. And so we've been really excited at the Foundation to be able to work 2 separate projects on social need and health equity. From 2020 through 2021, we were funded by the Washington Healthcare Forum to develop a framework to assess and address social need and health disparities. As we were going through that project, we found that a lot of this information is rapidly developing, and it's just an enormous topic. It could be an entire sector and program of its own. So we've convened a second project from the beginning of 2022 and going through December of 2023 to really work towards turning that framework into collaborative action. And so again, we'd like to thank the Washington Healthcare Forum as well as One Healthport for funding that work. Beginning in 2022, we convened a steering committee to guide our work, and I just wanted to say thanks to several of these steering committee members. I won't go through everyone's name, but I want to acknowledge that we've been really lucky to be able to partner with organizations such as managed care organizations, health delivery systems, public health agencies like the Healthcare Authority, as well as patient representatives and even employer purchaser representatives. And so I think we've really been able to get a representative group together to talk about what social need and health equity looks like in their organizations and communities and what we might be able to do to address that. Our steering committee was the group that initially determined our 4 priority areas for action. And so those 4 priority areas that we will discuss today include screening and interventions, storing and sharing data, and advancing equity. And the screening and interventions pieces, we actually convened 2 separate work groups on both of those topics, but I think we recognize and understand that those topics really go hand in hand, and so we are going to be discussing them together for the purpose of this event. And finally, before I do start to jump into an overview of our recommendations, one thing I wanted to highlight is how we are encouraging other organizations to use these recommendations. We really hope that these recommendations can outline actions that organizations can take, both individually as well as together, to offer potential standards when it is appropriate, but we understand that as a lot of this work is new, there may not be well-established standards. So instead, we try to offer considerations to help guide actions when we understand that actions might look different for local or community contexts. And finally, we hope that this work will lay the groundwork for future collaboration and alignment. And I'm really excited as we get to talk about what future sustainability looks like at the end of this event. So with that, I am going to jump into our screening and interventions recommendations. Again, this was 2 distinct work groups, so I'll start by talking about our social needs screening work group and what they focused on. Our goal here was really to move towards universal patient screening for social need information. And our screening work group determined that there were 4 key areas that we needed to look at in order to make that change. And that is planning and engagement, screening tools and domains, administration and workflows, and recording and communicating responses. And through our work group conversations, we tried to determine what best practices would be to implement a universal screening workflow in these 4 areas. So here I'm just providing some of those sample recommendations to share a little bit of what we've learned. For example, we do believe that a planning phase is essential prior to implementing social needs screening, mostly to develop buy-in with staff and leadership and patients, as well as to assess current capacity and ensure that efforts aren't duplicative. We also understand that even though our goal may be universal patient screening eventually, it's best to start with a vanguard phase or a pilot area to test screening and ensure there is an iterative process to respond to feedback from staff and patients about how the workflow is going. As far as tools and domains, we recommend screening for at least 3 social need domains: housing security, food security, and transportation need, which is in alignment with the Washington Healthcare Authority's goals, and using a reliable screening tool. We did not find enough evidence to encourage or recommend the use of a single tool, but instead we try to provide resources where organizations can find screening tools, with the understanding that sometimes screening tools are adapted to local contexts to meet the needs of local patients. We also spent a lot of time discussing administration workflows, and I think this is one of the areas where we see a lot of barriers, and so I'll dive a little bit deeper into that on the next slide. Because again, we understand that an assessment workflow must meet the needs of the local context, but there may not be single standards about how to implement. So we offer some guiding principles about minimizing burden, trying to make sure that we are connecting with patients and building trust through the process, and making sure that there is some sort of follow-up or communication occurring after someone screens positive. And finally, we looked at how to record and communicate responses, especially using content codes such as Z codes, which exist but are currently not implemented very well. So there may be some more training needs, as well as some upcoming updates to content codes for social need that are being developed by the Gravity Project. And we also discuss how to communicate these screening results across all key partners, both internally to make sure the care team is aware of what's going on with the patient, as well as externally if we're thinking about interventions and trying to create referrals. So one other piece I just wanted to talk about with workflow considerations is that we recognize that there are many different workflows for social needs screening. The 2 on the screen, the center one comes from the Boston Medical Center, and the screening workflow on the right comes from Kaiser Permanente's social risk playbook. And we know that screening workflows look different for different organizations, but some key considerations that we would recommend organizations think about as they look towards implementation include, if they want to include a pre-screening question, something you can see that in the Kaiser Permanente workflow, asking patients if they need assistance with social need first, and if the patient responds no, not moving forward with the rest of the screening workflow. If the organization wants to offer a paper screening tool versus electronic screening, such as something prior to the patient visit in the electronic medical record, and there might be barriers there given the electronic medical record or the technology capabilities of the organization that you might need to work through. Another key question is whether screening tools should be staff-mediated or self-reported, and there is some conflicting evidence on whether staff-mediated workflows introduce bias because patients are less likely to report social need when talking to a person, or if when properly implemented, staff-mediated screening tools through empathic inquiry or motivational interviewing can actually elicit a deeper understanding through a screening tool and actually get to resilience factors as well. And then the final piece that we discussed in our meetings were in-person versus virtual, or I suppose we could also say asynchronous conversations. So having an in-person conversation versus a telephone or a telemedicine conversation. And I think many of these will come down to the local contexts and resources that are available. But we wanted to highlight that there are many different ways to conduct screening, and we wanted to offer several examples that other organizations might be able to follow. But I think we recognize that we can't screen for social need if we don't have at least some plan in place or are working towards a plan to develop an intervention. And so we also convened a social need interventions work group. And this work group was really interested at looking at interventions on multiple levels. And so they took more of a socio-ecological approach to interventions. They looked at individual interventions such as care planning, resource referrals, and care coordination, but they also looked at what organization interventions might look like, such as investments and partnerships, and what these broader structural or systemic interventions may require for alignment and especially funding, sustainable funding. I won't go too in-depth into these sample recommendations. I just want to point out the places where we do make recommendations for action. We do believe that an individual intervention could be as simple as tailoring a patient's care plan to incorporate information about their social need, such as making a plan for medication storage if the patient is housing insecure, or making a plan to arrive at future hospital visits if the patient does not have a steady mode of transportation. We also tried to dive into some organization recommendations, and this is where we got a little bit into community information exchanges. I think many of us are aware of community information exchanges like Unite Us that are offering technology solutions for closed loop referrals. And here is a space where we don't recommend a single community information exchange, but we did try to recommend certain standards following the human services data specifications and making sure that the CIE platform is inclusive of referral management across key partners. The final piece that we looked at for interventions were these structural pieces. We know that we need to work towards alignment on social care integration, and a lot of that, as we've heard from many of our members and our community members, is it's going to require sustainable funding. And so we looked at some different strategies for sustainable funding, whether that's healthcare alternative payment models, investment in social services from public health or public agencies, or creating greater advocacy for policies that create the conditions that improve health so that we don't have to get to the point where we're creating individual interventions. So those are our broad screening and interventions recommendations. I know I went through them quickly, but I also wanted to highlight that we try to also provide a plan for different sectors within the healthcare ecosystem, understanding that different organizations have different roles to play. Health delivery systems may be responsible for orchestrating these workflows and allocating resources for intervention workflows, but it's also up to payers to help meet the needs of their enrollees and leverage coverage, reimbursement, and eligibility strategies, as well as public health agencies to be tracking these social need as a population health metric and directing sustainable funding and assistance towards social care integration activities. Finally, I did just want to point out that there are some upcoming developments that are incentivizing this work. So we do have some resources for screening and interventions, but the pieces on this slide that I want to highlight are the Joint Commission and NCQA standards on social need that are requiring that hospitals identify at least one domain for social need this year and then work towards developing interventions on those social need, as well as the new Medicaid Making Care Primary model, which Washington State was elected or selected as a pilot state for that program, which will involve more social care integration activities. And so I think we're really hopeful that these recommendations will be able to provide an initial framework or baseline for organizations that are trying to respond and adapt to these upcoming changes and regulations. But with that, that is everything that I wanted to share about our social need recommendations before turning it over to our speakers. And so we have invited two speakers to discuss what social need integration, social need screening, and interventions look like in their organizations. And so I'd like to invite up Patricia Gepert and Beth Weitensteiner. Patricia is a Health Access Senior Coordinator at the Washington Association for Community Health, and Patricia's work supports health centers around Washington as they work to reduce health disparities and increase access to comprehensive primary care services. Dr. Beth Weitensteiner is a physician and associate medical director or associate chief medical officer at International Community Health Services, a health center providing medical and dental care to Seattle and King County, Asian and Pacific Islander communities. So I believe we are going to start with Patricia's presentation. So Patricia, I will start sharing your slides, but feel free to begin.
Okay.
Well, thanks to the foundation for inviting the association to join the summit today to talk about the work that we do supporting social needs screening at Washington FQHCs. And as Nick told you, I'm Patricia Gepert. I'm the association's health access coordinator. If you can advance the slides. I want to share a little bit about the association for those who might not be familiar with us. The Washington Association for Community Health is the primary care association for the state of Washington, and we receive federal funding to support community health centers. Next slide. And our mission is to strengthen and advocate for Washington's community health centers as they build healthcare access, innovation, and value. And next slide. The association services include learning opportunities such as training and technical assistance, peer learning networks and collaboratives. And I'm going to focus on that in this presentation. And we also provide support around policy and advocacy engagement, workforce development programs, and strategic partnerships and relationships. Next slide. 27 federally qualified health centers are our members, with more than 400 clinics across the state of Washington. Next slide. I've included in the presentation some health center UDS, that's the Uniform Data System data from 2021, to paint the picture of the clients and the communities served by Washington Health Centers. More than 1 million patients were served in 2021, 15% of people in the state of Washington, more than 350,000 children under the age of 18, and 19% of women ages 15 to 44. Next slide. Now, some of the populations focused on include school-based health center patients, people who are unhoused, agricultural workers and their families, veterans, and those located in or immediately adjacent to public housing. Next slide. The health center clients are very diverse in terms of race and ethnicity, and more than a quarter are best served in a language other than English. Next slide. And more than 34% of Medicaid patients in Washington were served by health centers in 2021. Next slide. In terms of social determinants of health data, 19 health centers reported collecting data on social risk factors outside of data reportable in UDS, with 9 using the Prepare screener and 9 indicating they do not use a standardized screener. Many patients screened positively for social determinants of health domains of food insecurity, housing insecurity, financial strain, and lack of transportation. Next slide. So next, I'd like to touch on the association's history of supporting screening for social needs at health centers. From 2017, or from August of 2017 to May of 2018, the National Association for Community Health Centers, the Association of Asian Pacific Community Health Organizations, and the Oregon Primary Care Association hosted a Prepare Train the Trainer Academy. And the Prepare screener is the protocol for responding to and assessing patients' assets, risks, and experiences, which was created specifically for community health centers. The association was chosen to participate in the academy, and we recruited 2 health centers to participate. The association hosted monthly check-in calls with health centers where they shared what the association learned from the academy trainer calls, including the Prepare Implementation Action Toolkit, which was created. And the health centers discussed progress and identified issues needing follow-up. With funding from Kaiser Permanente from November 2020 to May 2021, the association partnered with Kaiser Permanente's McCall Center for Healthcare Innovation, the Community Health of Central Washington, and the Oregon Primary Care Association to host a social needs screening collaborative with 10 health centers participating. During the collaborative, the health centers selected a screening tool. They set goals and their approaches to screening. They mapped workflow, tested workflow and new approaches to care, and they planned for sustainable screening. The association hosted monthly calls, coaching calls with the health centers, and assigned homework. From September 2021 to August of 2022, Kaiser Permanente funded a social determinants of health work group for community health centers, which met monthly and enabled peer discussion, sharing promising practices and challenges, and trained on topics of interest, which included training on collaborative screening, setting up an SDOH data dashboard, screening agricultural workers, and also screening people who are unhoused. From October of 2022 to the present, the association's HRSA grant has funded a social determinants of health learning network for community health centers. It meets bi-monthly, and the health centers have been sharing their workflows. They've been doing training on closing the loop after clients have been screened. And next week, we're going to host a training on social determinants of health coding. And in the fall, we hope to train on how health centers are actually creating housing opportunities for their clients and communities, because they are just very lacking in their communities. So next, I'd like to share some themes that we've identified around screening at our community health centers. So in terms of barriers to screening at health centers, screening can be really time consuming for busy health centers with many competing priorities, and a small pilot project can be a good way to get things started and not be too intimidating for folks. The inability to get paid for screening clients is a big barrier. Some health centers are beginning to use SDOH coding to document this work, but none are getting paid. The lack of resources to meet all needs identified during screening is another barrier. Staff can be very hesitant about screening when they know that there are not resources available for all the social need domains. So it's really important to encourage them to view screening as a first step and to work on improving resource lists and building relationships with community-based organizations to meet those needs. The challenges of closing the loop after clients are screened is another big barrier. It's really important to share the SDOH data with the care team and to use it to inform care and to follow up with clients to make sure that they're able to connect to those resources. Staff turnover is kind of ongoing. It's a challenge as staff leave and new folks are onboarded at the health centers to really keep everybody well trained about the screening programs and to really keep them engaged. And finally, maintaining momentum and vigilance over time. As time passes, priorities shift, and it's important to really reinforce the importance of screening and how it benefits the clients and benefits the health centers. So next, I wanted to move on to the facilitators of screening at health centers. An important one is screening champions and staff buy-in. Taking the time at the beginning to really identify screening champions at the health centers and educating staff about what social determinants of health are and why it's important to screen really lays the foundation for doing this work. We don't want to assume that everyone is already aware of social determinants of health and will be enthusiastic about screening. Confirming that the screening tool is compatible with your electronic health record early in implementation is an important facilitator. Some health centers have run into pretty big challenges, which have slowed things down and required working, pretty closely with their vendors. So that's something you want to kind of address early on in the process. using a pre-screener to identify clients needing a full screener can be really helpful, so that your staff can kind of quickly focus on those with needs. And frequent staff updates and sharing data with them really keeps the staff engaged in the work. And periodic training builds a knowledge base among your staff, and it also reinforces the importance placed on this work by the health center. Participating in peer networking opportunities with other FQHCs doing screening and taking advantage of training opportunities is an important facilitator for the health centers. They've really valued opportunities to talk with each other about what works, what doesn't work, to share their workflows and materials, and to train with experts on topics that are of particular interest to where they are with implementing screening. So for the association, we really intend to continue supporting this important work through our Social Determinants of Health Learning Network. And I just wanted to say again, thank you to the foundation for inviting us to join you today and to talk about, you know, what we're doing to support social needs work at our FQHCs. So I'll pass things back to you, Nick.
Thanks so much, Patricia. Yeah, I think it's really useful hearing how participating in those peer networking and learning opportunities are a really strong facilitator, and we appreciate what the association is doing to develop those opportunities. But I will now turn it over to Beth, and I know Beth has an example from International Community Health Services and what you have all been doing there to integrate social needs screening into your workflows. So I will start sharing your slides, but go ahead and begin.
Thanks, Nick. Good morning, everyone. As Nick said, I am the Beth Weitensteiner, and I work for International Community Health Services. And we are an FQHC with vision for healthier people, thriving families, empowered communities, and a just society. And we are, as previously mentioned, deeply rooted in the Asian Pacific Islander community. But our goal is to provide culturally and linguistically appropriate health and wellness services and promote health equity for all. Next slide, please. So this is a picture of who we served in 2022 and kind of a little bit about us. We have 11 locations in Seattle, Bellevue, and Shoreline, including 5 standalone clinics, and we are engaged in 2 school-based clinics. We are, as most FQHCs and CHCs are, full spectrum, provide full spectrum medical care, including medical, dental, behavioral health, and vision. And you can see that our principal insurance is Medicaid. What's unique about ICHS is that we are truly an international organization in that most of our patients do not speak English as their first language. And so that brings an overwhelming diversity and color to our organization in terms of power and making us strive more and more for ensuring that health equity and services are across all cultures and provided in a manner that our patients can understand. Health literacy and just literacy are 2 things that we work on every organization. You can, they live all across King County and Snohomish County and down into Pierce. So everything about the organization is broad. Next slide, please, Nick. So for social determinants of health, we started, as Patricia mentioned, with the prepare form. And that was a huge step in identifying a way to help us identify patients who would need assistance. And as we struggled with the prepare form in identifying how we could make it culturally and linguistically appropriate for our patients, and then translate that into a meaningful, objective form of care. And so initially we would just ask people, collect the data, and it really didn't do anything. we identified patients who needed help with food, and we started to carry food resources. We have a cupboard full of food bags to provide an immediate acknowledgement of a need and put them out with something tangible. But otherwise, we were still struggling on what do we do with all of this. In 2020, when we went from our previous EHR to Epic, all of a sudden there was a more tangible way to take that prepare form and crosswalk it into what Epic had already structurally set up. And so then we had a way to kind of mine data within their SCOH model. But again, what were we going to do with that? How are we actually helping our people? And so in 2022, we identified and received grant funding for what we now call our patient navigator team. And we added them to the workflow, which meant collecting the surveys, providing real-time information or follow-up based on the patient's needs and if the patient wanted it. And our goal was to collect annually for all patients, and that included pediatric patients. If we didn't care for the parents at our clinics, we at least would get a family perspective of what their needs were. Next slide, please, Nick. So this is just an example of our current SCOH questionnaire, and it is a combination of prepare, and you can see that the English version on the left side of your screen is a one-page front-sided itemized thing. And we can send this out to people who have my charts, and we can send it out electronically before, and then patients can opt in, opt out. And then at the very bottom, it's like, would you like to see an ICHS patient navigator to contact you with resources? And a simple yes, no. On the right side of your screen, you can see the same survey interpreted and translated into Vietnamese. And you can see that all of a sudden it became a two-sided, and I didn't show you the backside to highlight what our patients go through. And that this survey all of a sudden became long, and so patients look at one side and they don't realize there's something on the backside, and I need to turn it over. And so then that all-important question, would you like help, doesn't even get addressed. And so we learn by our mistakes, we learn by launching and looking back and going like, wow, that just didn't work. And so we're working on capitalizing how much of this in English do we need to have for the patient navigator, because they can come in with the English version of the form. And so we're working on revising this so it becomes a one face sheet look for the patient. And then we get that all important yes, no mark. It didn't help for patients who do not have literacy in their native language. And so then we need to be able to have an interpreter there to go through the form with the patient one-on-one. And so then when that happens, then we're able to get to both sides of the form and then get that warm handoff to the patient navigator if the patient is so inclined and has the available time at that moment of that visit. Next slide, please. So this, again, not that it is gold and concrete and the perfect workflow. This is an iteration of kind of where we are now. We are continuing to revise this, but you can see there were a lot of steps that went through it, and there were a lot of iterations of this as we went through it with PDSAs, with one provider, one PN, patient navigator at one clinic, trying to figure out what works, what doesn't work. But we have two kinds of identifiers. And the important thing is to decide internally for your organization, how often are you going to survey? How often do you have time to survey? As Patricia mentioned, finding the time, finding the resources, getting the buy-in, all of those things take a lot of effort, and they don't come with a lot of financial resources to back that up. So we've identified, we would just like to get it done, one patient at least once a year at an annual exam is our goal. If we identify a patient who has not been seen for an annual exam but has frequent follow-ups, then we try to identify them and capture them. And so then we also take and follow through on, if the patient has my chart, we can send them a form out and we can have them pre-fill, and then it is ready at the time of the visit. Otherwise, at the day of the visit, the patient checks in, is provided the form, and then is helped to complete the form if they need that, with interpreters that are at the site for each of the visits. And then the patient navigator starts the whole process of actually tangible responses to the patient. And so if the patient is requesting assistance, then while I might be in seeing the patient for their annual exam, the patient navigator is reviewing the form, sends me a secure chat message and says, when you're done, I'm happy to come in and talk to the patient if they have time today. If not, we'll set up a time later. And so a lot of coordination back and forth between all of patient navigator, provider. And so again, if you have buy-in, for us, that one-time annual visit, it's really important. And so we're all willing to kind of do whatever we can to kind of facilitate our patients' needs. An important part of the survey now, again, is, does the patient request assistance? And so then we move through with that. And if they say yes, we're all hands on deck. If they say no, we respectfully will adhere to that. Next slide, please. So I asked our patient navigator teams, they've been at it now for almost a solid 6.5, 7 months. What are their impressions? What are their barriers? Because as a provider, we see one side of it, but they're the ones that are really doing the hard work for us. And so their impressions are undeniable that social determinants of health are an important cornerstone for primary care and patient health. And I think we can all agree on that. And the connections between any organization's patient navigator team, or whatever you want to call that team, and other community-based organizations, nonprofits, agencies, all of those things, it takes a village to move this forward. And so all of those interconnected resources and access to all of those resources are critical. And so what our patient navigators are doing is they're, depending on which clinic they're at and what resources are available in the immediate neighborhood and geographic location of that clinic, they're trying to utilize those first and foremost, like maximize what's close to the patient, what's close to the clinic. And then also utilizing whatever else they can scrounge together to get that patient going where they need to go. The barriers that they have is that some of the organizations that they would like to send the patient or route the patient towards, the strict eligibility requirements keep the patient from getting those resources. Transportation, a huge problem for our patients. And that issue is compounded by the fact that many English is not their principal language. And so how do we get them along the way? I have a patient who comes from Kent, and it is 3 bus rides and a light rail to get to the clinic. And it's complicated for her. So anything we could do to facilitate that. But again, I think it speaks also to the appreciation and the understanding that the patients have when they endorse their patient-centered medical home, their clinic as their own, and they will go miles to get to wherever you are, because they know that the care they're going to get is meaningful to them. And so they're willing to do that. And so whatever we could do to ease that burden, I think we would really want to take a look at. One of the food bank issues that comes up for some of our patients is when they're undocumented and they're not allowed to get in because they need ID. And so our patient navigators have been trying to work around how do we get some kind of identification to kind of facilitate this. Paperwork, always an issue. There's a lot of it. And so is there a way to make that burden a little less for the team that's actually doing the work? Again, transportation, super, super hard. Next slide, please, Nick. So my question to them was, if I gave you everything, what would you do with it? And we're already working on, there's great effort being spent in a lot of this, but the first answer was get the comprehensive database of available resources in the community with qualifying conditions so they could navigate everything. When our PN team is meeting with local organizations, those organizations sometimes don't know what other local organizations are doing. And so everything comes through word of mouth. And so there's not a one-stop shop for everybody to find all those resources. Increasing funding for all of this work, would be great. It would help with to mitigate understaffed scenarios and or the overworked scenarios, which I think we can all endorse. And one of our young patient navigators, he just said, make it more affordable to live in Seattle. And that may be a bigger picture item. Next slide, please, Nick. So what are our next steps? So we're continuing to work on how do we gather data, how do we analyze it, and how do we make it tangible for our patients, because that's why we're a response to the need, and how can we do that? And then how can we bring the clinic and the resources at the community to a central location? And we're looking into that with mobile medical opportunities, a medical van. Instead of my patient coming all the way from Kent to South Seattle, can we take a medical van out there and deliver care in the community? Can we do community-based maternal support services? Can we get our prenatal care out there and alternate clinic-based and community-based and find a balance there? What can we do to our SDOH referral system inside of the EHR? Can we get referrals that will be generated electronically and go to the organizations so we can kind of ease the paperwork burden on all of this? And no matter what, we're going to keep working on it. We're going to keep trying. We think it's valuable to our patients, and that makes it important to us. And so we're willing to employ all ideas and try to figure out what we can do next, what we can do better, and how we can improve.
Thank you so much, Beth. And I really appreciate you being willing to share some of those workflow pieces and some of your screening tool pieces with us. I think that's a great example that everyone will be able to learn from. I know that we have some limited time, but I do want to try to get to some of the questions, at least 2 questions, and then maybe we'll need to move on to our next session. The first question that I just wanted to highlight, I know it's a relatively small question. Oh, it looks like it's answered. I think Patricia shared the webinar on using Z codes to document SDOH work in the Q&A box. So if anybody's interested, that's in the answered portion. And then we have several sort of clarifying questions for Beth, maybe one that we can get to right now. There is a question from Karen Birmingham. If patients decline assistance, is there an effort to determine why? As in, do you ask, are they embarrassed to accept the offer, feel intimidated, etc.?
Yeah, definitely sometimes the patient is more willing to talk to the provider than to a patient navigator. And so if the patient navigator is seeing that resistance, or not resistance, but just like unsure if I want to engage in this conversation, then often what they'll do is they'll just switch it back to the provider and say, you have the relationship. Could you confirm? Is there anything I can help with? And usually we facilitate that prior to the patient navigator even coming in. Is I'll usually talk to my patients because they've already sent me the secure chat, and we'll just go back and forth a little bit with, you expressed this need. Can we help you with this today? I'm going to introduce you to Russell. He's a part of my team. And so they just need to know that part is okay. Like, you're not going to on me up on somebody I don't know, and I don't know what I'm going to get. So trust is a big part of all of this.
Definitely. Yeah, thank you, Beth. I know we have several other questions. So Beth, if you are able to stay on, if you'd be able to type answers as well.
Yeah, I'll type those in to everybody.
Perfect. And then we will, though, need to move on to our next section. But thank you so much, Beth and Patricia. I really appreciated hearing what you're doing to help support clinics in undertaking this screening work. We know it is a very big lift, but there's the potential to really improve outcomes for patients. So thank you both for being here today. All right, so I will return to sharing my screen as we move on to the next big focus area for priority action that we determined through our social need and health equity work, which is storing and sharing data. And I think that we really saw that this is a big issue because we know we're trying to collect a lot of this social need information. There's also been big pushes to collect better, high quality sociodemographic data, race ethnicity data, sexual orientation, gender identity data, things like that. But we are also haven't reached a consensus for many of these standards yet, and our systems aren't really well set up to be able to aggregate this information for population health reporting purposes to really help us track need and track effectiveness of interventions. And so our steering committee determined that storing and sharing data was an important topic to focus on. So our storing and sharing data work group specifically looked at different data standards, the important use cases for using demographic data, common capabilities to meet those use cases, and then we made some comments about interoperability as well as guiding principles, really thinking about the ethics of big data systems and understanding that there's also the potential for harm when we're collecting this much demographic data. The first piece that I want to highlight are these sociodemographic data fields. And I think, again, many of these are in flux. And this is an area where we tried to point to standards where they exist, but we understand, especially when it comes to race ethnicity standards, there may be limited standards, but we know that they are incomplete. And so we offered some of these resources for specific sociodemographic data fields. For social need data, we pointed to the Gravity Project terminology workstream, which has been looking at Z codes, but also other content codes that may be useful for social need. They've been working domain by domain through what codes might look like, and then they propose those codes to the ONC to get built into future contracts. And so I think that's an organization to keep an eye on. For race and ethnicity standards, unfortunately, we still are pointing to the OMB standards currently, with the understanding that those are rather limited and there are some issues with flattening disparities within groups and being able to choose multiple different race or ethnic groups as you're filling out the forms. So we tried to understand that that is a limited standard and advocate for expanded lists. And I believe the OMB has done some work to offer an expanded list as well as the CDC. And then when it comes to some of these other categories, there's not great defined standards. So for example, with language and disability, some of the existing, at least federal national standards come from the census questions for these categories. And then for sexual orientation and gender identity, we tried to point to some existing organizations doing this work with the understanding that this is often in flux as well. So we pointed right now, at least, to the Fenway Institute and the Human Rights Campaign. And one thing that I wanted to highlight about these sociodemographic data fields is that we know that through Washington State Rule 22-13-187, which was adopted by the Washington State Department of Health, there are expanded sociodemographic data fields that need to be collected at least by hospitals. And so we've been continuing to do some work there to see how those categories overlap with the categories we're recommending, and if there's any additional guidance needed, especially around definitions, especially looking at sexual orientation and gender identity. As far as use cases and common capabilities, this is a piece that I will be honest, I am not as knowledgeable about data systems. It was my pleasure to convene this work group and learn more from some of our data and IT experts. But I did want to share that we looked broadly at 3 important use cases for sociodemographic data, which were how we're collecting that data at the point of care, how we use that data to meet patient needs and communicate across stakeholders. And so there's a little bit in there about workflow orchestration, some information about closed loop referrals, and how we are integrating with community information exchanges. And then a third use case for the generic consumption, which from what I gather from our data partners means that the aggregation and analysis of data beyond the point of care. And so we did talk about how data systems can respond to custom data requests and improve analytics capabilities for research and consumption. And so this is all rather technical, and we will have our full report up likely by the end of the month on our website with some more information about these capabilities, but I do want to give some time for our other speakers to present at what's going on in their organizations. The final two pieces, though, that I want to highlight is that we do want to continue the move towards interoperability. We're borrowing mostly from HIMSS models here to define interoperability and interoperability levels, which we're encouraging organizations to continue to move up on those interoperability levels. And we are trying to work towards the move towards FHIR, and there are several FHIR resources with the Gravity Project as well as ONC as well. And then some of the considerations that we were thinking about as far as ethics go are appropriate data collection, making sure that we are conducting data collection in a human-centered, non-stigmatizing way, data integrity and accuracy when we're reporting on disparities, as well as principles for data analysis to avoid blaming and shaming specific groups, and then community and person ownership over their data autonomy, as well as data transparency. And so those are some principles that we think are important. Again, we don't enforce those specific standards in these ethical considerations, but we do think that they are important. And we think that organizations should be thinking about those principles as they develop their own data systems. This final slide just shares some of the key themes and considerations, most of which I've already talked about, but I do want to talk about some of those upcoming developments. I've mentioned the OMB expanded categories, as well as the Washington State rule for hospitals. I think it's also important to note that NCQA is beginning to stratify certain HEDIS measures by race and ethnicity as we move towards more reporting of health inequities. And I think it's important to note that when we're talking about some of our common capabilities, the Department of Health and One Healthport are working on a chronic disease surveillance project to improve the state's capacity for monitoring chronic disease and creating quality improvement projects. And a big part of that conversation has, again, been how to incorporate social need, because we know that social need plays a big role when it comes to chronic disease. And so I just wanted to highlight some of those upcoming developments and opportunities for alignment to look out for. I will go ahead and stop sharing my screen again, though, because I do want to have time for our speakers on data. So for data, we have representatives from Molina Healthcare and from Swedish Healthcare who are going to talk about how they're using data in their systems. From Molina, we have Ryan Williams, the Vice President of Technology, and he will be joined by Jessica Beach, Molina's Health Equity Director. And Molina Healthcare is a multi-state managed care organization that provides health insurance through government programs such as Medicaid and Medicare. They've been serving Washington for more than 21 years and have over 1 million enrolled members here in Washington in particular. They will be presenting first, followed by Vinny Fox, a program coordinator for LGBTQI+ education at Swedish Healthcare. They developed and teach a course for Swedish employees about LGBTQIA training that includes health disparities, historical context, and information about sexual orientation and gender identity data collection. So I'd like to first invite Ryan and Jessica up to present, and I believe, Ryan, you were planning on sharing your slides.
Yeah, sure. Well, thank you so much, Nick. And I'm going to attempt to share my slides right now. And while I'm bringing that up, I just want to thank you and Ginny for the opportunity to be part of this committee and participate with you on a regular basis. It's been a huge learning experience for me, as well as, you know, I'm really glad and pleased with the outcome of the recommendations that we have, and hopefully it can help all of us in the state of Washington really propel forward on this topic here. You know, a little bit today, so we'll talk a little bit about you know, SDOH use cases. You know, Nick, you had mentioned a little bit previously in the webinar about some of the closed loop referral CIEs, the Z codes and things of that nature, and just how technical we got in our committee meetings. And so I won't bore our audience today around kind of the technical nature of storing and sharing data. But what I did want to talk about it a little bit was with the wealth of data that we get today, how is Molina using that? And then what I'll do is Jessica will take it over from there and talk about race, ethnicity, and language data at Molina, how we're doing, along our journey there, and some considerations about it. And so, Nick, thank you for the introduction around Molina. So I won't spend too much time here. We've been in the state of Washington for more than 20 years. As Nick mentioned, we are the largest Medicaid and marketplace health plan in the state with over 1 million members. So if you're doing the math at home, that's roughly 1 out of every 7 Washingtonians will be a Molina member. We're highly focused on quality. We focus on making sure that we take care of our providers, and we're #1 in provider satisfaction. So we'll move on so we can make sure that that everybody has a chance to talk today. So first thing I wanted to talk about in regard to SDOH and how Molina is leveraging knowledge and capabilities around SDOH is our Molina Help Finder. And this was really born out of the necessity for our care teams to really have tools around who are those community-based organizations that we rely on a regular basis, as well as governmental resources that are accessible to our members. The old school way of doing it was having a Rolodex, and you pull out your Rolodex, and lo and behold, I know this person at this organization, I can call them. And of course, in a modern era, where we do a lot of remote work, and in addition, we have, as people come and go and leave organizations, whether it be CBOs or within Molina itself, I mean, you don't want to lose that knowledge. And so, we needed a technical tool to do that. And so it just so happened that the technical tool that we have and that we work with also is available to our members directly on our public website. So I don't know if we have any Molina members on today's webinar, but molinahelpfinder.com is how our members can access the Molina Help Finder. And you'll see the screen capture that I put in here. I just put in a Seattle zip code. There's more than 2,900 programs just in that Seattle zip code available to our members, and it is available across every zip code within the state of Washington. So it's pretty exciting. So if there's something available for our members or for providers to refer to our members, it hopefully is in this tool. So for any providers that are on the call today, we do also have links for you to actually have a closed loop referral. You can reach it through the provider portal. If you go to the payer spaces for Molina, you should be able to find it pretty easily there. If you want more help finding it, contact your provider services rep. But back to Molina and internal, this is the data for closed loop referrals is tracked by our care teams. We make sure that there's follow-up. And this has really become a tool that's propagated throughout our entire organization. So we share it amongst each other and make sure that we're making sure that we have the right information for the members. And if we don't have the right information, we go out and seek that. So it's just a great way that we've been leveraging technology and have some data in action going on there. Next, and I won't talk too much about this, but Z codes. I know that the utilization of Z codes is really widely varies based on organization, and from a data and action perspective, just so you all know, I mean, we do collect all that Z code information when it is sent to us through claims, and we aggregate that data. And so, we heard from about some of the screenings that are occurring in an SDOH screening form, which was great information. It's neat how we evolve our data collection practices to make sure we get the best information and make sure that our members get the help they need. So it's great hearing the previous presenters. But we also have health risk assessments that we do on our side as well. And so, if you start to marry those things together, the screenings that we get, assessments, as well as connecting all the Z codes, it really gives us powerful data to understand, well, who are our members that need support? And so we aggregate that. We have propensity models that we use internally. And so we're really trying to get smarter every single day in regard to the data that we collect, specifically around Z codes. And so I know that it's not necessarily, as Nick had mentioned, it's not necessarily part of the recommendations of this committee, but we do need to start evolving, as a healthcare community in regard to how we use that data. So with that, I do want to pass the baton over to Jessica. Jessica, are you with us?
Yes.
Oh, Jessica, good deal. And as Nick had mentioned, Jessica is Molina's esteemed leader of health equity. And so with that, Jessica, I'm going to pass over to you, and you can talk about REL data, and just let me know when to push the slides forward. Okay.
Great. Thanks, Ryan. And so we presented on the REL data a couple of weeks ago. And so this may be a bit of a refresher for folks who are part of that discussion, but I think in my work with health equity and cultural competency, the REL data is it's really important because it helps us to really understand who it is that we're serving, who are our members, and begin to think through how we can work as a health plan to best support their unique needs, support providers in enhancing the work that they do with specific populations. It really guides how we make decisions. It informs our actions and priorities, and things like budgeting and where we focus our work as a plan. And then there's also like the required component, right? So the reporting that we do to the state is the REL data is becoming really critical piece of how we report back to the state the work that we're doing. Can you go ahead and go to the next slide, please? So the next piece I think that's really important to discuss around REL data on the payer side is where do we actually get our information from? And so there are three big areas where we get information that we can look at it through the lens of race, ethnicity, and language. So the first is enrollment files. So we get those directly from the state on a regular basis. What's important to remember about this is the self-reported data from our members, often when they're applying for benefits. So it's a point in time snapshot of our members, but it's also, we have to remember the space that our members are in when they are sharing this information. And so there could be some hesitancy to share self-identified information. There may not be that level of comfort there. So we do often see a certain percentage of blanks or just unreported information. So we often use that information with other sources. So that goes on to the next section, which is the internal data collection. So there are other ways where we can get some of this information, the initial health risk assessment. We also collect some information about provider race, ethnicity, and language. Sometimes this information will come to us through claims or grievances, but that's really how we can overlay what we know about our members from the enrollment information on top of claims and grievances and other data resources that we have to better understand disparities or issues that are happening. The real kind of boost, I guess is a good way to say it, to what we know directly from the enrollment files often comes from external data. So state reporting, community reports, community needs assessments, surveys like BRFIS and PRAMS, like that gives some good information. Also, like the maternal mortality report, things like that, that the state will put out. We often try to pair that with what we know about our members and the enrollment, and to get a fuller picture of what those experiences of our members are, what they look like, how we can support needs in those spaces. And then I feel like by putting all of these data pieces together, it really just gives us that additional context around what communities are experiencing, what our members may be experiencing, what our providers and other partners are experiencing as well. Go to the next slide, please. All right. considerations, these are just things that we think about. I mentioned this earlier, it's a point in time snapshot of our members and really what they're comfortable with sharing. The O and B categories, so this is something I know that gets talked about a lot when it comes to REL data collection, because it gives very prescriptive categories in which race and ethnicity roll up into, and it makes it hard to really truly capture members who may be multiracial and really capture how a member wants to self-identify. And then we also really like to think of the data that we have access to on the REL side as really a step one. We don't want to really make any decisions based solely on data. We really want to have that member perspective. We want to have community and partner perspective, and through that partnership, identify what is the best way for us to act as a payer and as a health plan. And I've already mentioned this, but the member perspective is really what we try to keep at the center of our work. How are our actions going to impact our members? How does the data that we're looking at inform how we respond and are responsive to the needs of our members and partners? And go to the next slide. Oh, and that is the last slide. So I know that was really quick, but do we do like questions now, Nick, or are we moving to the next?
Should we hand it over to Vinny maybe to make sure there's enough time?
Yeah, thanks, Ryan. So yeah, I think I'll go ahead and invite up Vinny. I really appreciate you sharing all of the work going on at Molina, and I think it's great to see this from a health data systems perspective. And I'm excited to invite up Vinny because I know they've been working more at maybe a provider and data collection level. And so I think that will give us a great different perspective of how we actually collect this data in a person-centered approach. So Vinny, I do have your slides and I'm happy to share them for you.
Well, great, thanks. It looks like for some reason my camera isn't working. Apologies, maybe I'll get lucky and it'll start cooperating. It's been on the fritz for a couple of days. So hi everyone, just a quick introduction. Hi, I'm Vinny. My pronouns are they, he, and as said, I am the senior program coordinator for LGBTQI+ education. I'm also the team lead for the LGBTQI+ program. So when it comes to staff training, we have just recently been able to roll out some SOGI specific training. We have done training in the past through an LGBTQI+ introduction training that did go over, as said, health disparities, historical context, the state of LGBTQI+ care at Swedish, and we briefly touched upon sexual orientation and gender identity data collection in that training. However, because it is such a more complex thing, and due to lots of staff questions about data collection, we developed a SOGI specific training. But especially now with the new CHARS law coming out and the new collection terms that are included with that are much more vast than the previous. Really needed to be able to get out that kind of training to make sure that staff was prepared for this, what is going to be a much more complicated and much more in-depth collection of demographic data from our patients. So the things that we mostly focused on with the training were knowledge, conversation, and the technical aspect. So knowledge, we're talking first and foremost about the terminology, because as I said, the new collection contains so many more terms than the original setup that we had in the EPIC system. I think we went from like maybe 5 to 7 choices to like 10 to 20, depending on the category. And a lot of those terms are ones that a lot of people don't know. So being able to establish a glossary and a base knowledge of that terminology, focusing on kind of an overall knowledge rather than, okay, you have to know what every single term means, but giving that resource to staff so they're able to go and understand what kind of terminology is going to be going in there. Another thing we want to really focus on is why are we collecting this information? Because that's one of the biggest things that I would get asked is, why is this important? Why do I need to know this? Why are we even bothering getting this? And the biggest thing is, sorry, my brain decided to stop for a second. The biggest things are data collection, because if we're able to get this important demographic data on our patients, that helps us find gaps in care. We can identify inequities and disparities in those populations. And we've already been able to start seeing that in some of our LGBTQI+ populations, seeing that there were higher rates of diabetes, uncontrolled diabetes, high blood pressure, lower rates of cervical cancer screenings, breast cancer screenings, colon cancer screenings in these specific populations, because we were able to get that demographic data. It was also about showing respect for our patients, because we're acknowledging that we have a diverse patient population, and acknowledging that not everyone is cisgender, not everyone is straight, and that we have all these different communities that we do need to be able to acknowledge. And all of that just leads to better care, because when we're making medical decisions made based on facts, not assumptions, and it gives us a better understanding of who patients are, so we're better able to serve them. Last thing for knowledge that we really focus on is HIPAA and safety, because someone's sexual orientation and gender identity is considered protected health information, so it falls under HIPAA. So basically reinforcing that idea with the staff, because we all go through HIPAA training so much. But just reinforcing that, yes, someone's sexual orientation, someone's gender identity, these things are protected, and outing a patient, disclosing to someone that this person is possibly transgender, this person is gay, this person's a lesbian, that is a HIPAA violation. So making sure that staff understands the importance of keeping this information discreet and private, not only for HIPAA reasons, but also patient safety. Because if the wrong person hears somebody is a member of the LGBTQI+ community, that could put that person at risk of harm. So making sure that that is a key component of the knowledge that we're imparting to our staff. The next part of the training that we focus on is conversation, because nobody knows how to ask these questions. Nobody knows how to ask somebody about their sexual orientation, about their gender identity, even about their pronouns. Those are things that most staff aren't trained on. They aren't aware of it, and that leads to people just not asking the questions because they feel awkward, because they feel intimidated, because they feel embarrassed. So focusing on when it is appropriate to ask the question and how to ask the question. It is not always appropriate to ask these kind of questions. And I like to fall back on just before you ask anything, ask yourself, do I need to know this? Treating it like any other medical question that you would deal with. Someone comes in because their stomach hurts, we don't need to ask about sexual orientation. It's not relevant. Just like if someone's coming in to say that stomach ache, we don't need to ask them if they've had headaches recently. It's not relevant. We don't need to be going through their chart looking for that information if it's not pertaining to the reason why they're there. So focusing on explaining situations in which you would need to ask these questions. For like a new patient, we want to ask all the questions because we're trying to do intake. For a physical, we're trying to ask all questions because we're trying to get the most complete medical history that we can. Someone's coming for sexual or reproductive health, we might want to ask about their sexual orientation so we know what kind of partners they have. Someone coming in for gender affirming care, making sure we do have their gender identity on file, so we make sure that we are being respectful and giving them appropriate care. Going into how to ask these questions, making sure that our wording is correct, and providing scripting for the staff so that they are better prepared to ask these questions. Presenting it is asking open questions, not just what's your gender? How would you describe your gender? How would you define yourself? Letting the patients lead the conversation, let them define themselves with their own terminology, their own terms, their own language, and making sure that we are documenting exactly as a patient defines themselves. Another important thing is who is asking what questions, because not everyone should be asking everything. So the SOGI collection that we have in EPIC covers preferred name, pronouns, sex assigned at birth, gender identity, sexual orientation, affirmation steps and plans, and organ inventory. So like preferred name and pronouns, everyone should be asking those things because it's part of addressing someone. We want to make sure everyone is addressing people properly. Mostly focusing though with our front desk staff, our non-clinical staff being the ones to really collect that preferred name and those pronouns so that can be entered in the chart so everyone is able to see that going forward. Then we go for our more sensitive things, gender identity, sexual orientation, sex assigned at birth, having that focus more on our clinical staff. specifically our medical assistants, our nurses, people who are rooming patients, so that they are in a more private environment, so they're able to collect that information discreetly. Of course, again, when it is relevant to the reason the patient's being seen. And then leaving the most sensitive things, the affirmation steps and plans, the organ inventory, to our providers, to our ARNPs, to our PAs, our healthcare practitioners, to be asking those most in-depth medical questions. Lastly, making sure staff is prepared for adverse responses. Not everyone is going to react positively to being asking these questions, and just having staff prepared to know how to de-escalate these situations when someone is upset at being asked about their sexual orientation, about their gender identity. Letting people know that we are asking everyone these questions. We are not singling them out. If they do not want to share, that is perfectly fine. All of these questions are voluntary. We are asking everyone, but no one is obligated to answer, and then shutting the conversation there and moving on. So it does not escalate into an argument. Also making sure staff is prepared for people who might be confused about being asked about these things, so they're able to answer questions and provide them resources and information so that patients feel more comfortable sharing this information. And lastly, of course, with training, we have to know the technical. How are we even doing this? One of the biggest things that we saw when we started really focusing on SOGI data collection is that most people didn't even know that the tool existed. When I started collecting and tracking our SOGI data collection rates, this was July of last year, we were consistently in about 30 to 35% collection rate, because most people did not know about the tool. The tool was released in 2018, but the training that was put out for it was voluntary, so participation was low, so knowledge was low. And since we have been able to put out more information and get more people knowledgeable of the tool, we've gone from that 30 to 35% up to almost 50% collection. We're just teetering right there on the verge. They are getting to 50%. Hopefully we'll be crossing that threshold soon. But just giving people the basic knowledge of it has shown that much of an increase. So letting people know that tool exists, where it is, how to find it, how to use it. So the training that I do does go through a step-by-step process of, this is where you click, this is where you find it, and then also going into the little nuances of it, because not everything is intuitive. And unfortunately, the tool, while it has been updated and has a lot more better features now, doesn't have everything. For example, for pronouns, you cannot select multiple pronouns, and not every pronoun is available as an option. So knowing how to put in multiple pronouns, how to put in pronouns that are not listed as selectable options, making sure that people are aware of these workarounds so they're able to accurately put in this information. And then
Vinny, I don't know. I don't think I'm able to hear you now. And I don't know if that's a technical issue.
Nick, I can't hear either, so I wonder if we're having a tech issue as well. I hear them.
Right. I'll go ahead and bring us to this next slide. But it looks like, oh, Vinny, are you back? Are you?
oh, there you am. Oh, and now my camera works. Sorry about that. I don't know what happened there. I guess my internet decided to stop cooperating. Apologies. Where did it cut me off, just so I make sure that I'm...
I think you were just wrapping up the previous slide, so then I moved on to this slide.
Okay, great.
Yeah.
So apologies if you can hear my dog. Apparently he is very upset right now for some reason. So I apologize. I don't know what is upsetting him. Give me 1 second. I'm going to go put him away so he is not barking this entire time. Apologies.
So, hey, Nick, this is Ryan. While we wait for Vinny to come back, there were a couple of questions in the chat. One was around Molina Help Finder being available to all Molina members, not just Medicaid. Yes, that is true. And access is publicly available. And I put the answer in the chat. And then somebody asked, what's a propensity model? And I'm so sorry. I speak data and I speak technology, and I oftentimes forget that sometimes I live in my own world. And so for those that were curious what a propensity model was in reference to the Z codes and how we aggregate data, propensity model is basically a statistical approach that predicts the likelihood of something occurring. And in this case, for SDOH, we predict the severity of a person's SDOH needs. So a fancy term, but in practical terms, it's not that fancy.
Yeah, thanks for answering the questions, Brian. Yeah, we might need to move on to our next session without questions, but I'll let Vinny go ahead and wrap up this slide before we move to the next portion of the event. Thanks,
Okay,
Vinny.
I'll just keep it brief then, and again, apologize. The joys of working from home with an elderly dog. Getting brain back on track. So one of the biggest things we run into with people not collecting SODA information is that awkwardness that I mentioned earlier, because these are sensitive topics and we have societal taboos that block this kind of conversation. People feel awkward, they feel intimidated, feel uncomfortable, and that is completely normal. And letting staff know that it is okay for you to feel this way, because that's fine. Everyone feels that way. But because we are medical professionals, we need to be able to overcome these mental blocks so we can put ourselves at ease and make our patients more comfortable in the conversation. This is healthcare. We ask uncomfortable, awkward, embarrassing questions all the time. This is just another one that we need to get used to being able to talk about. And also addressing that one thing that we did a survey of our providers asking about how often they collected this information. And one of the reasons that was presented that people didn't is that they felt that the patient would not feel comfortable answer these questions. But through our data collection, we saw that it was actually the providers who were more likely to have that issue of feeling like they can't ask the question rather than the patients feeling like they can't. So we like to emphasize that patients most of the time will answer these questions without issue or decline without any kind of pushback. And they understand that we are collecting this information to make sure we are taking better care of our patients. We're getting that important demographic data, that it's going to be used by caregivers who are providing direct care to patients, and the how is going to be used in quality care. So we can make decisions based on accurate reports, not assumptions. And most importantly, that's going to be private, because as we talked about earlier, this is covered by HIPAA, is protected health information, and we treat it as such. So it's only to be accessed by those providing care to the patient, and only when it's relevant to their care. Making sure that we understand that patients are the ones leading the conversation, making sure that we are letting them just find themselves, and emphasizing that we want to always ask, because assumptions lead to errors. And you can't always tell someone's sexual orientation or gender identity just by looking at them. That's how we get a lot of errors. So making sure, even if you have known this patient for years and years and years, unless you've never asked, you can never truly know. So making sure that we are emphasizing that it is better to ask and have that awkward conversation than to assume and make a wrong judgment call. And I don't know how much time we have left, if there is any time for questions. Otherwise, if anyone puts them in the chat, I'd be happy to answer them up there as well.
Thank you so much, Vinny. Yeah, I think for now we'll go with, if there are any questions, please insert them in the Q&A box. And Vinny, if you're able to stay on to answer some of those, that would be great. And to both you and Ryan and Jessica, thank you all for presenting on data. I think we got several different perspectives, from how we're using data systems to what standards we're using, then to how we actually ask patients about this very personal information in many cases. And I think we do need to be thinking critically about how we're collecting that data and creating trust. I know that was a big portion of Beth's presentation as well, and perhaps a big theme of this event. But thank you all. I am going to move us to the final one of our recommendation updates, which is on equity. And so please bear with me while I share my screen. Perfect. So I wanted to just acknowledge that I mentioned that we had conducted work on social need and health equity in 2020, as well as then again in 2022. And I think one of the greatest oversights in our initial work from 2020 to 2021 was that we didn't focus as much on pieces about advancing equity and addressing especially racial and ethnic disparities and other demographic disparities. And so I think this time around, we really got to highlight some of the pieces for how we can encourage organizations to move forward and address the inequities that they're seeing in their sites. Our Advancing Equity work group really wanted to focus on three main pieces, which include the equity planning and making sure that it is an actionable equity plan with dedicated resources, as opposed to just a statement that doesn't really bring with it much change. And then they also wanted to focus on using data and using policy. So just to highlight several of those recommendations on leadership, data, and policy that we were focusing on, we wanted to encourage organizations to make health equity a strategic priority in leadership, including embedding equity principles in mission, vision, values, and programming, with actionable health equity plans, dedicated resources, and working towards a culture of equity. And I know a lot of that is broad, and difficult to find standards and specific best practices, but we do try to point to several resources that can help guide organizations through this work, and I'll get to that in a different slide. A lot of our data pieces actually overlap with the presentations that we just heard about how we're capturing sociodemographic data to better understand health inequities. For example, the example that Vinny was giving about the relationship between poorly controlled diabetes and the LGBTQIA community, and perhaps there are some specific interventions that can be developed to address those disparities. And then finally, we wanted to look again at policy, both organizational policy, how the organization's physical space is set up, whether the organization has specific policies that are including underserved communities or people of color, and how we can advocate for public policies that advance equity. As I mentioned, I just wanted to highlight some of those further resources with good healthcare organization equity frameworks, including the Institute for Healthcare Improvement, the American Hospital Association, and the American Medical Association and CDC have some strong guidelines for communication as well. This is another area where we see the opportunity for future growth. There are Medicaid quality incentives that encourage organizations to develop health equity action plans. And there are upcoming Joint Commission requirements for 2023 that deal with how organizations are working to reduce healthcare disparities. So I think that there's a lot of opportunity and incentives for future action on health equity, and we just wanted to highlight some of those initial steps that can be taken. Again, we recognize that different sectors within the healthcare ecosystem have roles to play. It's not just health delivery systems that are working to provide equitable, holistic, effective, and high quality care, but also payers who can leverage purchasing strategies, consider the impacts of their policies related to coverage and eligibility, and public health organizations that can work on public policy and facilitate partnerships and alignments. This final slide summarizes most of what I said previously. Some of the things that I would encourage here that I don't think I've talked about yet are encouraging joining a health equity action collaborative. I know that there are collaboratives with WISHA as well as with the Foundation for Healthcare Quality, and consider how new requirements from the Joint Commission or Medicaid quality incentives could be applied to your existing equity work. And then there is some overlap, as I mentioned, with some of those data pieces that we were just talking about. So I think there's a lot of movement around equity that we hear, and one of our strongest messages from our work group and that we want to keep encouraging is just to make these health equity plans actionable and move towards intervening on disparities or inequities once they are identified. And a lot of that may involve partnerships with communities or new innovative clinical structures. And so I think we're really excited about the opportunities for future growth in this area. Again, I'm going to stop sharing my screen because I believe we have our representatives from the Fred Hutch Cancer Institute who are going to talk a little bit about how equity is seen in Fred Hutch's programs. So I'm going to pause. Okay, it looks like Kerry is joining us, and I will begin to share the slides. But before we begin, I do also want to say we're going to be joined by Kerry McMillen and Wendy Law. Wendy Law is the Associate Director of Administration for the Fred Hutch UW and Seattle Children's Cancer Consortium. Dr. Law trained at Fred Hutch as a graduate student and postdoc before taking on her new role as Associate Director of Administration. As a student and postdoc, Dr. Law was involved with the Hutch's grassroots diversity, equity, and inclusion efforts. We're also joined by Kerry McMillen, who is a board-certified specialist in oncology nutrition and a fellow of the Academy of Nutrition and Dietetics. In addition to her work with Fred Hutch Medical Nutrition Therapy Services, Kerry has also been working with Fred Hutch's work groups to integrate social needs screening and interventions into their care delivery programs. So, Kerry, it looks like right now we are waiting for Wendy to join. Would you like to start with your portion of the presentation? Or any further introductions?
Sure, thank you, Nick. I know she's on because she was asking about how she might show up on Zoom. So there may just be a little bit of a technical glitch, but I'm happy to see. I think we may be having a technical issue. She's teamsing me to say that she's showing up in Zoom as Cancer Consortium, but I don't see her on here quite yet.
Okay. Perfect. I see her. I will promote her now.
Got it. Okay, great. Thank you. I'll stay tuned. There she is.
Hi, sorry about that, Nick. My computer likes to rename me, so.
Well, we're glad to have you here. Thanks for joining.
Yeah, you bet. Thank you very much, Nick, and to the Foundation for inviting us to speak. We are really excited to share some of the efforts that we have ongoing around advancing equity at the Fred Hutch University of Washington Seattle Children's Cancer Consortium. Next slide, please. So our Cancer Consortium is one of 70, actually, I was just notified today, there are now 72 centers across 36 states in the country that are designated cancer centers recognized by the National Cancer Institute, that's NCI. And we are the blue dot in the upper left-hand corner of that map. And we are happy to be serving not just the state of Washington, but the state from which we receive the most patients behind Washington state is actually Alaska. And we have a regional presence in our collaboration with the University of Washington throughout the Pacific Northwest. The designation as a comprehensive cancer center indicates that we excel at research in fundamental basic sciences, clinical research, and population science. In addition to conducting world-class research, we are also a clinical care organization, and that's what we'd like to share with you today. So next slide. The NCI Comprehensive Cancer Center status was first conferred to the Fred Hutch as a freestanding cancer center in the early 1970s after the National Cancer Act was signed by President Nixon in 1971. In the early 2000s, the Cancer Consortium was formed with Fred Hutch as the lead institution and having UW and Children's joining us in the consortium itself. Next slide. So for this, the next 2-3 slides, I'm going to focus solely on Fred Hutch for a moment and talk about Fred Hutch's institutional commitment to diversity, equity, and inclusion efforts. We have a DEI core, which provides ongoing support to our workforce and our leadership through culture shifting activities and tools based in data. So I've listed quite a few things that our core leads. but I'll focus on two main things. One is bias mitigation training. These are live learning opportunities with our colleagues. They're mandatory for all staff, all the way up to our president and CEO. So he too takes this training. And not only is it's not a one-time online training where you're checking the boxes, but there's pre-work and post-work, which calls us to really think about our positionality within the institution and the intersections of all the identities that we hold within ourselves. And the other thing I wanted to talk about is at the bottom, our annual DEI report. These are snapshots of current initiatives, programming, and events, and reflections about the work ahead for us. We published publicly data sets about our workforce itself. So one of the most important things guiding our efforts is really data, which I know that you've already talked about today. Next slide. So this is a snapshot on the data on our workforce. It's available on our website. And we realize that without data, we can't track trends and know how well we are doing around recruitment and retention. And so we collect detailed information and use this for our self-assessment to know if we're moving the needle, and also identify needs that need more attention. So if you look at the line under executive leadership, compared to our overall workforce, individuals from BIPOC communities are far less represented amongst our executive leadership. And this is consistent across scientific, clinical, and administrative groups. Within clinical operations, and particularly in nursing, we have the largest proportion of female identifying individuals in our workforce. And we have different racial and ethnic populations represented here, with 36% of this part of our workforce being BIPOC. And if you go down to looking at professor track faculty, we know that we conduct research, which is very important, but these same faculty are also the physicians that see patients. And you'll see some generational differences here. The full professors who are more established are predominantly male and white. However, if you look at the assistant professor population, which is our newest generation of researchers and physicians, they're over 50% female and 48% BIPOC. A particular note is that 7% are underrepresented minorities in the scientific workforce. And for us, it's a 5% increase in the proportion of URM assistant professors as compared to the previous year. So we're really proud of all the efforts that we've done to recruit these new faculty into our workforce. And of course, the challenge now is to maintain a supportive environment and an inclusive environment so that we retain them. And so I think that's something that we don't talk about as much, but definitely the retention piece is almost more important than recruitment, because if you can't keep people, it really is detrimental to the culture in general. Next slide. So the other activity I wanted to share about is a task force that we had in 2020 on inclusion and equity in research. And this is an important activity that was across all three of our consortium institutions. We had over 50 stakeholders from all three institutions participating in this activity. It was a 6-month task force in order to examine our current practices and resources to enable research and clinical care. And we wanted to be able to gather recommendations for improvement and furthering our efforts. So these working groups, there are 6 different themes and topics that drove these working groups. And at the end of it, we provided over 50 task force recommendations to leadership in June 2022. And what we're doing now is we have prioritized initiatives for action, and we've made budget requests for FY24, which for us starts July 1st. So we're eager to know what things we're going to be embarking on very soon. And as Nick mentioned earlier, you know, lots of talk without resources to actually do the work doesn't get very far. So we are very hopeful that many of these will be funded in our next fiscal year. Next slide. So examples of task force recommendations and things that we are moving forward are include piloting navigators expressly for clinical trials participation. So similar to what a patient navigator would do to help our patients access their care and complete treatment successfully, these navigators would help with trial participation. The second pilot is to examine the decision-making processes made by patients and providers leading up to offering a patient clinical trial participation. We want to identify barriers to participation for the patient, but also know more about the factors that prevent trials from being offered on the provider end. So having information about both sets of decisions that are being made is really important. The third is tracking demographics of our participation in our trials. We've been doing this for a long time, but now we are being more proactive in flagging those trials that are struggling to recruit from all of our communities widely, and we're flagging them so that we can intervene and help them be successful in their recruitment. And then the final thing that we're hoping to do, we've just done a feasibility study on having a Office of Patient Engagement. And this would be a standing office where we can engage patients and researchers together along that continuum of research activities, from deciding what kind of research is being done, study design, implementation, and then dissemination back to our communities. Because we don't want to take our ideas fully baked to the community every time and then just saying, does this look good? We want to be able to engage them in deciding what's the recipe you want to make with us, and really starting at a very early time point. Next slide. And my final thought is that intersection with public policy is really, really important. So House Bill 1745 just passed and will be effective in a little over a month's time. And what this bill does is compel state institutions, including the University of Washington, to improve diversity in clinical trials. So we really want to make sure that the research that we do is inclusive of all the communities within Washington state, and that the results that we gain from the research that we do is broadly applicable to all the communities that are in our state. So because this is such a new policy, we are still figuring out a lot of details, but we're absolutely really excited to be partnering with all consortium institutions on these efforts. And of course, again, one of the most important things guiding these efforts is data. So I can see that a lot of data will be collected and used to assess our efforts. But yeah, more to come. Maybe we'll be invited back next year to talk more about this. But to provide an example of what is happening on the ground at Fred Hutch, I'd like to introduce my colleague, Kerry McMillen. She's the Senior Manager of Clinical Supportive Care, and she's going to be sharing with you our implementation of SDOH screening.
Thank you so much, Wendy, and it's a pleasure to be here with you all today. If you could advance to the next slide, please, Nick. So before I really launch into how we came up with our screening ideals for our social determinants of health work, I would be remiss not to acknowledge a few key participants. So we actually do have the benefit here of having a health equity management team. So I do want to acknowledge Brandolyn Bergstead, who's the director, and then Tiffany Go and Calbeth Alaribe, who are our health equity program managers. I also really want to call out the incredible engagement we've received from our EPIC team. None of this would be possible if it wasn't for their incredible knowledge and really designing a tool that's patient-centered. I know Chrissy's on the call, so I just want to call her out as a huge component and champion of this work. And lastly, I just want to acknowledge people who are often the undersung heroes of many of our screening projects, which are really the frontline staff, including the front desk folks who check people in, as well as the MAs who are often the ones asking these questions if they're not completing the screen in advance. So thank you for allowing me this moment, but I really don't feel right standing up here speaking to this work without acknowledging that this is really a team effort and calling out some really specific people who have supported the work. So that said, we did want to really put forward a let's just do it approach at Fred Hutch and make sure that we have something that we can run through a test run for our social determinants of health. And I wanted to outline our screening goal. First and foremost, it's really to use a health equity and patient-centered lens in how we implemented this. So of course, we want to meet our commission or our joint commission requirements. We also want to meet our CMS requirements. But what we really wanted to dive down to is how do we have a consistent experience for all of our patients who are coming in as new patients? And how do we leverage MyChart functionality in EPIC and really make sure that the data that they fill out is visible? I totally agree with what Wendy said, is data is really important. We do not want patients filling out forms that state they have a need and no process in place for getting them connected to a resource, whether that's a tangible need or a social worker who can help dive into counseling around interpersonal violence and things like this. We also really wanted to think about how do we include our patients that are either in the digital divide, they may not have access to MyChart, or perhaps they are non-English speaking or even non-English reading. So we wanted to have a workflow in place to really make sure we're as inclusive as possible. And similar to my point about leveraging MyChart functionality and making sure data is visible, that really entails a timely follow-up from our supportive care team. So really wanting to get our hands around those metrics and what is workflow and reasonable expectations to set. Next question, or next slide, please. So you are likely very familiar, but just to be clear, these are the screening domains that we chose, and we're using the questions that are embedded in EPIC. So housing instability, food insecurity, transportation problems, utility help needs, and interpersonal violence. What's important to note is that patients can decline to answer the SDOH screening questions at any time. They are welcome to decline screening overall, or there is an actual option on each question set to decline certain components of the screen. And I also want to call out the incredible value and insight we've gotten from our Patient, Family, and Advisory Council, who we took this to, because similar to what Wendy said about clinical trials, we also want our patient and family advisors to be making this recipe along with us. I love that analogy as a dietitian, and making sure that what we're implementing and the verbiage we're using to introduce the questionnaire, et cetera, really resonates and makes sense to people who will be receiving it. Next slide, please. So what we designed is the following workflow. It's pretty nifty, I have to say, because it really does leverage EPIC. And what it does is that the survey, so the SDOH survey, is automatically linked to new patient appointments. So we had to identify what all of those were. And then once the new appointment is scheduled, the MyChart survey notification is sent to the patient. The patient will complete the survey in MyChart, or as I mentioned previously, there is a paper version if the patient did not complete this in EPIC MyChart. What's great is that EPIC has a functionality, as many of you likely know, where the survey responses are scored automatically. And what we did is leverage the silent BPA feature to ensure that the in-basket message is sent to the appropriate supportive care team member. Then the supportive care team member would receive that in-basket message and either contact the patient if that's appropriate to discuss and or schedule the consultation or put an order in for that consultation to be scheduled. Next slide, please. So here's just an example for those of you who may not be familiar with it. On the left-hand side is what the patient actually sees in Epic. So these are the questions that are validated for food insecurity and transportation needs. And so we have a dedicated system where we've defined what will route to become a positive referral. And then on the right-hand side is an idea of the paper version of our SDOH questionnaire. And you can see right at the top, there is an explanation as well as the option to decline the entire survey. And then within each question, an option to decline as well. Next slide, please. So the way that we can really maximize Epic functionality is, one, we're utilizing the questions that are embedded in Epic. The reason that this is important is it does allow questions to be scored automatically to determine if they meet the threshold for an in-basket notification. And what's really even more great is that when we're talking about patients across our medical system, what's fabulous is that our questions will automatically populate to the SDOH wheel in Epic. So I just put a little snip here, and you can see that when a patient screens positive for a specific domain, it turns red. And what's really great about that particular feature is it's highly visible in the EMR. And if another team member went into the chart, it's very easy to know where to go to find this information. And this information is updated as patients continue to be asked these questions. So in the future, we don't have this yet, but we do have the goal of defining what longitudinal screening looks like. And we'll be able to see a timeline of what the patients answered when on a flow sheet or on this wheel, and then be able to determine if there are still issues that need to be addressed by looking at this. Next slide, please. As I mentioned earlier, it is really important that we are addressing patients who may not be speaking or reading English or may not be comfortable filling something out on my chart. So we based our translated copies on our top 5 languages, which are listed on the left. And what we did is we worked with our interpreter services team to have the questionnaire be translated into these 5 languages. So this is just an example of the Vietnamese translation. So the workflow would be that if a patient checks in at the front desk, we want to ensure that the front desk person has a way to ask them if they filled out the SDOH form. If they say no, they can either fill it out on a clinic provided iPad or a paper copy in English. If they don't speak English, they would, and they do speak one of these top 5 languages, they can fill it out on paper, and then and then the MA will then receive this form and enter it into Epic on behalf of the patient. If they don't speak English nor one of our top 5 languages, there would be a connection with an interpreter who would then answer these questions or go through the survey with the patient so they can still be included. Next slide, please. So in terms of our pilot design and how we do the supportive care follow-up, just to go through the example. So if a patient completes the survey via MyChart or a physical translated form, as soon as that form is entered, the silent BPA sends off the in-basket notification once the chart is opened. And if a patient screens positive for a tangible need issue, such as food insecurity, housing, transportation, or utility assistance, automatic in-basket notification is sent to the patient navigation team, and then the patient navigator follows the workflow for either contacting the patient or places a referral order. If a patient screens positive for interpersonal violence, the in-basket notification goes to social work, and then the same process unfolds. The social worker would either contact the patient or places the referral order. Next slide, please. So work ahead, as I mentioned, this is a pilot project. I'm happy to report that this was approved for further rollout in one of our QAPI goals. And we did complete our SDOH pilot in our GI clinic. This was a 4-month pilot, and approximately 8% of patients screened positive for one of the 5 SDOH domains. We were able to embed full distress SDOH screening into another pilot we have running around our Commission on Cancer Distress Screening. So we combined the survey to be one combined survey. There's a lot of in-basket notifications that would then route through due to malnutrition risk or distress, or depression or anxiety, too much to go into right now. But we do plan to roll out this combined screening to other Fred Hutch clinic locations between Q1 and Q2 of our fiscal year, which, as Wendy mentioned, is July. And at this time, as we are just launching SDOH screening for the very first time at our institution, we'll be mostly focused on active treatment patients at this time, but certainly have work groups involved with thinking about how do we really roll this out across more clinics and to patients even coming in potentially for screening appointments or the longitudinal pathway. That's the end of my formal presentation. And I think there is a question, and then I apologize, but I do need to scoot to a next meeting.
Of course, yeah, I think there's at least one question asking about how the SDOH questionnaire gets translated into ICD-10 codes or other content codes.
That is a really wonderful question, and we are talking about how to do that, but that's not currently defined. And I think that's really important, again, because as we can start to make linkages with data and using sort of predictive modeling, I just came on to the last call where someone was talking about how do you predict potential SDOH needs or linkages throughout, you know, other things that you may not think about, like marital status or SOGI data, or is there a link between food insecurity and malnutrition, and what other avenues can we go down and really help serve patients proactively? That's really the goal, is how to get needed resources to patients as easily as possible. I know that's a big task, so I say that knowing there's a lot of work to come, but I really, really appreciate being included in this, and I'm happy to take further questions via email. But I think it's really exciting work, and patients truly have been appreciative of us asking this question. I think that's important to note is we've had comments of appreciation, and just confirmed last week that we have had no formal patient complaints around this. And that's an important thing, because we certainly don't want to be doing a process where patients are uncomfortable or actually complaining about the workflow we've developed. So it's early stages, maybe we'll get some complaints, but anyway, it's an exciting time to all be working on this stuff together.
Perfect. Well, thank you so much, Kerry and Wendy. If you're able to stay on and continue answering questions in chat, that would be great, or we can forward them to you via email. But I really appreciate your presentation, and I think you did a great job of highlighting how our efforts on health equity, especially through demographic categories, race, ethnicity, sexual orientation, and gender identity, are connected to some of our work on social needs as well. And we know that there are many different dimensions of inequity that we're working against here. And I appreciate you sharing at multiple levels too at the Fred Hutch organization. So thank you both for being here. I know that we are running a little bit behind time, but I wanted to give everybody in the audience time for a quick break still. So we'll go ahead and take a brief break, at least through for about 5 minutes, which I guess would take us closer to 11:08. But we'll plan on returning in about 5 minutes to continue our conference with the remaining presentations and panels. So thank you everyone for being with us this morning. And I hope you're able to take this as a quick health and well-being break. Thanks. All right, well, welcome back, everyone. Although I do recognize that as this is a webinar, I'm sure many of you are still able to take your breaks as needed, but in the interest of time, we will continue to move through our content today. So after our break, we're turning a little bit away from the discussion of our recommendations as well as case studies to a more broad conversation about how we can create sustainable action together. So basically, what's encouraging organizations to act now? What's the role of public health agencies as connectors between healthcare agencies and social service agencies? And what are some of our next steps? Where are we able to go from here? And so hopefully over the next hour, we'll be able to dive a little bit more into some of these broad conversations and broad topics. So first, I want to invite Ugbag Hassan from the Community Health Plan of Washington to talk about making the case for change. Ugbad is a licensed clinical social worker and a program manager for health equity at the Community Health Plan of Washington. She is committed to patient advocacy and social justice and helps develop new initiatives and structural support frameworks to meet CHPW's health equity goals. Ugbad, thanks for being with us this morning.
Thank you so much for having me. Perfect. Hi, everyone. My name is Beth Hassan. My pronouns is she, her, and I am one of the program managers of health equity at CHPW, Community Health Plan of Washington. And we're just going to talk about a higher overarching journey of our equity in terms of health equity, health disparity, and internal equity as well. Next slide. So before I get started, I just wanted to talk about who CHPW is. So we were founded by the Washington Community Health Centers and are governed by and rooted in social justice movement. And we are currently serving over 315,000 Medicaid, Medicare, dual, and exchange members. And we are in all the counties currently, which is exciting to be able to serve such broad in Washington state as a whole. And we have about over 600 employees, mostly located in Washington state, but we do have certain individuals around the country. And for my next slide, it will highlight a timeline of how we started doing equity at CHPW. So we started our journey in 2018, and we started with the multicultural healthcare distinction being awarded by NCQA. And from then on, we've been on this journey. 2019, we were able to be part of the national teams to participate in advancing health equity, collaborative with Healthcare Authority, Washington Health Network, and it's been a journey that led us to developing more of this. I will talk more about that actually. So we created Immigrant and Refugee Health Alliance Group within CHPW and the network 2019, and that was due to the administration and what was happening to better support our members. And 2020, we included equity into our strategic planning to be leader and pursue a whole person healthcare and equity and to center that. 2021, we were able to find intervention that was chosen by our CHCs and collaborate with them and made the Learning Collaborative, which has been going on for 3 years. And we also 2022 and 2021, we've been on a DI and just providing measures of where can we improve in terms of health, staff, and to better serve them, not only our members, but make sure that our staff are also being taken care of. And then currently, we're still building capacity in leadership and staff. And we hired our equity and Chief Equity Officer of DEI. And it's been wonderful to be able to figure out what it means to be an organization that identifies as anti-racist organization. So we're currently working on that. We'll talk more about it. And we are pursuing health equity accreditation, which I am so glad. We submitted it yesterday. Our team has been in charge of that. So it's been a heavy lift. So we're looking forward to going through that journey, but we officially done for that. And the next one, next slide. So in order to support our overarching strategy, we believe it is essential to continue intentionally developing both internally and externally with around diversity, equity, especially working with externally facing work and promoting understanding and holding ourselves accountable. And I'll talk more about how we're currently doing more of that accountability holding at CHPW. Next one. So from that journey, we've been working on these 4 pillars. So applying equity to all our strategic equity to all of our work. And one of the ways we're doing, I'll go more into it in the next one, but the second one is reducing health disparity, and then becoming anti-racist organization and creating equitable work environment for all of us. And we did this with, of course, as part of being advanced health equity, and it's been quite the journey. Next one. So these are some of the work that's being done under those 4 pillars that we're currently working on. We embedded equity into our strategic planning to make sure that we're holding ourselves accountable, it's actionable, and we can accomplish it as time goes on. And reducing health disparity has been one of the top priorities of ours. And as I mentioned earlier, when we developed the Equity Learning Collaborative grant program, it has been 3 years. So what we do is we partner up with our clinics, and they choose an equity issue that is impacting our members, particular members in that clinics, and then we work with them. We provide them $50,000 grants, and then also work with them monthly, whether it's a bigger group or more focused groups. And it's been wonderful to see the changes that can happen, and to also have our clinics choose and have autonomy as they see what issues are coming up at their clinics. And then becoming an anti-racist organization, we do understand it's a journey. We are constantly working on that. But some of the ways that we've been able to implement is we've been able to do implicit bias training for all of our members. So this took place in 2021. And now we also do it for anyone who gets hired. So it is a foundation training to make sure that everyone understands our values as HPW, and we are also working on developing more trainings to make sure that we understand that how health disparities and biases and all these things can impact our members and their health. And then the other way we have been able to do it is the Immigrant and Refugee Health Alliance Group. I am one of the co-chairs in that space, and we've been able to, my colleague Connie has been a wonderful leader in that space as well. So we talk about how we can better support our members that are refugee and immigrant, and some of the work we've been involved recently, it's like the landscaping for undocumented individuals. So we want to make sure that we are getting communities to be involved in those conversations, and it's not just us going into the communities and saying, hey, let's help you, but rather be a resource to that community. And then last but not least, equitable work environment is really important, and making sure that our staff are feeling heard is really important. And one of the ways that we do that is the Diversity and Inclusion Advisory Group. It was developed 2019, and it's been a great space to talk about what things that we can do to better support our staff members to make sure that they feel their needs are being met. So that is another work that's being done. Next slide. And to go just a little bit deeper to show some of the topics that are coming up in our learning collaborative. The Equity Learning Collaborative is this. So we do have a DEI group, and maternal health, as like social determinants of health data collection. So these are the topics that are selected by our clinics. So we are just there to be able to support, to provide resources to better support them. And this launched in 2021, and we have every intention of continuing from here on. And it's been a wonderful way to engage and also give back to the community. Next one. And another way that we've been able to work on as we're embedding equity into our strategic planning, this is a goal 5, and we created health disparity report last year to better support our members, but also as we're going through data collection as one of our focus in making sure that we are getting SOGI data, real data, and making sure that also our members know why we're collecting those information. There was a lot of people that talked before me that did a great job of highlighting the importance of people knowing why they're being asked. We are health insurance, we do understand that, and just being mindful as how we ask those questions. So, and our disparity report highlighted some of the disparities that are impacted by underserved communities of color. So what we're doing this year is that we learn from those, and it was 8 measures that we wanted to improve. And now this year we are working with our regional care teams to use a model to address those identified disparities. So it's been a journey to just see how that could be done, intervention. So we're in the middle of the phase of figuring out how we can better support that, but it's been wonderful to also see, but constantly learn to see how we can better support from the community and also member-facing individuals. It's easier to write a report and to see those, but to directly get information from members that are impacted, and also to see our member-facing staff and what they're telling us has been wonderful. Next. And oh yeah, of course, health disparity, health equity accreditation is also another way that we've been able to work on some of the gaps and making sure that we put things in place to better support our members. And our strategic goal 7, it is focusing on equity and making sure that we are being intentional about it internally and externally. But this particular one is more internally faced. As I was mentioning earlier, we did hire a recent 2 individuals that will be doing DI. We have a program manager and our chief equity, and we are currently working on prioritizing the equity council work plan and how to better support that work, and just navigating what it means to be anti-racist organization. I think there's just making sure that everyone understands, but also providing the resources of our staff understanding what that means. We've been working on developing tools, resources to better understand that. And also one of the other ways that we've been working on this is diversity in leadership. So we are constantly evaluating and seeing the numbers and making sure that we feel like our members are reflected by our staff as we serve them. Next slide. And reflection time. So these are some of the things we've been learning, and it's a journey. So we're constantly learning how to do things better. Our CEO is very much committed to health equity and holding the organization accountable, which is the reason why we're putting it in our strategic goals and making it actionable, so we can make sure that we can hold ourselves accountable, and incorporating it also into the annual health equity goals, into whether it's strategic, the goal 5, goal 7, all of it. And we do understand that equity data governance is also really important. The way we collect it is important, and the way we reflect our members is important, but we also understand data is not the only way of telling that story, and making sure that we are constantly in communication with communities we work with has been a learning curve as well. And then linking quality and equity and making sure that we're dedicated to improving health equity and advancing health equity for our members, but also for all of us as well. And then next one. What are some improvement? Of course, I think when we first started asking SOGI questions, the reaction has not been the best, and understandably so. I think we need to do a better job of educating. So just slowing down and making sure that it's not linear and it's never completed, constantly learning about that. And then health equity, excuse me, health equity can also be siloed. And what we're learning is that our organization has been making an effort to connect all the departments. So it's not just our department that works on it. So we've been doing a lot more across the organization, making sure that we include it into all the work. And it's not something that should be just a lens for a particular group, but rather a fabric of what we do. So making sure that we hold ourselves accountable and also stop and learn consistently to say, what are the ways that we can improve, and finding creative ways to involve others and holding ourselves accountable for that work. External work is not going to happen without, of course, internal equity work. So just making sure that we build more strong foundation into the work, which has been our journey, and we're constantly learning about that as well. Next slide. And I'm all done. I know there was a lot thrown at you all. Does anyone have a question?
Yeah, let me check in our chat real quick. There is one question that was asked about, are there any chart audits being done to look at patient chart note language?
So our case management team does do that.
Okay.
I just personally, sorry, let me try to read the question, the whole question, to look at patient.
Yeah, and it also asks, there is much language that is used that contributes to bias and disparities.
So for the auditing and making sure that language, I think it is a case management role that makes sure that that's being done. And I think that happens frequently. And then the second part to that question, is there a language that's used contributes to bias? I don't know that I fully understand that question. Is the language we're using? I think we're constantly monitoring ourselves and making sure that we are improving. Our language is not being biased, but of course, implicit bias is there. And that is one of the reasons why we're constantly doing trainings to make sure that we acknowledge and learn from that, but also improve it to better support. And I think the other thing we're doing in conversations we're having currently is that when we're working on disparity, how do we take away the blame on the individual? And I think that happens frequently where it's like, oh, that person doesn't want to go, if it's a low attendance for, I don't know, member showing up to an office appointment. How do we take away the blame from the individual and ask, what is it that we're doing that prevents these members being reached? Some of the work that's being done is our adolescents, in particular communities of color, that's also lacking numbers really low. We're working with HCA with that and all the MCOs. So those are some of the languages we've been making sure that we shift the blame from individuals and think about the system level. So we are working on that.
Perfect. Well, thank you so much. The other question that we received in the chat is just, that was great. So I would say thank you. And I appreciate the focus on what you've learned about what is encouraging for conducting this work through your leadership buy-in and through making sure that health equity is really well integrated at every step. And I think that's really a great reminder for all of us as we go back to our other organizations. If you're able to stay on, there might be some more questions in the Q&A box, but for now I am going to invite up our next panel about connecting to community. But thank you for being here.
Thank you so much, Nick. This was lovely.
Thanks. Perfect. So we're now going to promote our next group to panelists and begin our Connecting to Community panel. I think one thing that we found throughout our work in social needs and health equity is that there is really a gap between connecting healthcare organizations to community organizations. And one sector that does a lot of work around this issue is public health, as well as our accountable communities of health in Washington state. And so we're going to be hearing from 3 different agencies in different geographic areas of Washington state who are currently working to connect people to community organizations in order to address their health and social needs. And we'll have some time for some questions in the chat to talk about how your organizations might be able to get involved in your area of Washington. So briefly, I'll just do 1-sentence introductions, and then I'll turn it over to the panelists to introduce themselves further. But we are joined by Jan Capps, the Community Health Worker Unit and Racial and Ethnic Approaches to Community Health Manager at Public Health of Seattle and King County. We're joined by Eric McNair Scott, the Director of Community Clinical Linkages at the Southwest Washington Accountable Community of Health. And we're joined by Allison Polson, the Executive Director of Better Health Together, the Accountable Community of Health in the Spokane area. So we're going to first invite our panelists to introduce themselves, and I believe we'll have Jan with Public Health of Seattle and King County go first. Oh, Jan, it looks like you are muted if you're speaking. Perfect.
Yeah, sorry about that, folks. I didn't realize I had not turned on my video. Good morning, everybody. As Nick shared, I am Jan Capps with Public Health Seattle King County. I'll say I'm still involved in the what we call REACH project, Racial and Ethnic Approaches to Community Health, but I'm not the program manager of that anymore. I am still the manager of the Community Health Unit, though. So thanks for having me. So do you want me to go ahead and get started?
Yeah, please do.
Yeah, okay, great. I'll say this has been such an interesting discussion today that it inspired me to whip together a really quick slide just because of what I've been hearing folks talk about and sort of the different ideas that I've been percolating. When I was hearing the discussion earlier about how public health can be involved with equity work and looking folks, I just thought about 2 of our projects and kind of the domains of, starting with data, selecting strategies and interventions, and then supporting and engaging community. I want to make sure people can see my slide. Yeah, okay. So 2 of the projects that we've been working with, the REACH project, Racial and Ethnic Approaches to Community Health, what we did was start with the data. So we were looking at regions, this is a CDC funded project, looked at regions where at least 20% of the people were living in poverty in a contiguous area. What were the health disparities of people in those regions by race and ethnicity? And we worked with community to do that analysis. And then we worked with a governance team that represents community to select interventions from a menu of options that were provided by the CDC. We provide at least half of that funding that we receive goes directly to those community organizations. And they assume the responsibility for implementing the sub-strategies in coordination with the project as a whole. And we sort of have a similar path with a different project that we're just about to start, which is the Airport Air Quality and Asthma Project, which we call AAA. And so we again started with the data. We examined the health disparities between people who live within 10 miles of SeaTac with the rest of the county, and presented that to community and stakeholders. And within that analysis, we found that asthma was one of the leading health disparities, particularly among children. And so at the request of the Washington state legislature, we chose to work on asthma, and we chose a community health worker intervention that our organization has been developed and tested over 20 years. And we also chose to do more study about whether ambient air quality is a factor rather than other environmental conditions. So, folks who live near the airport have poor quality housing. So is it the housing stock, or is it the airport that's causing the or is it poverty that is causing the asthma? So we wanted to do a deeper dive into that. And so also with this project, at least half of our funding is going directly to support organizations in the community. Our plan is to contract with clinics and CBOs to do community health worker intervention. And our program will be the training and support for those CHWs. And we're going to do, and we have already done more analysis of the racial and ethnic populations in that region and the race and the languages that are spoken to ensure that our partners represent and are reaching those most in need in our community. So that's an example of two different projects where we've taken this public health approach to do analysis, select interventions, and partner with community.
Perfect. Thank you so much, Jan. I really appreciate the specific examples there. I think both of those projects are really interesting. We have a lot to learn about how to engage with community health workers and how to reach out to communities. Next, I'd like to invite Eric to talk a little bit more about Southwest Washington ACH and what you've been doing to connect with the community.
Sure. Can you all hear me? All right, great. Okay, well, it's a pleasure to be here as part of this BREE collaborative panel with Jan and Allison to share our experiences and learnings. I'm Eric McNair-Scott, and I work at the Southwest Washington Accountable Community of Health as Director of Community and Clinical Linkages. And our ACH, as it's called, covers 3 counties, Klickitat, Skamania, and Clark counties. The acronym for our ACH is SWATCH, and so we go by SWATCH. Over the past 5 years, funded through the HCA's Medicaid Transformation Project, SWATCH has developed out a community hub called the Health Connect Hub, and I'll mainly be speaking on the Health Connect Hub today. In 2020, we partnered with the Department of Health to leverage the Health Connect Hub to respond to COVID, and we integrated with the Department of Health's statewide technology infrastructure called Care Connect Washington, which I hope some of you have heard of. Care Connect Washington supported, strengthened, and helped align community hubs across Washington state. To date, SWATCH's Health Connect Hub has connected over 5,000 people with complex and intersecting needs and risks to a regional cohort of trained, trusted, and highly skilled community health workers. I want to talk about the value of community hubs. Community hubs are valuable because they're regionally responsive, locally accountable, and guided by community needs and priorities. Community hubs address the problem of siloed services and fragmented systems by providing a central coordinating infrastructure while centering and supporting the community-based workforce and the network of community-based agencies that employ them as key drivers for community health improvements. Partner agencies and resources are aligned to support the common goal of providing the right care to people when and how they need it. There are no eligibility restrictions for referrals or support from the Health Connect Hub. While we have priority populations that guide outreach and equity engagement strategies, any community member may be referred into the hub, and once the referral is received, a CHW will be outreaching to that community member within 2 business days. So it basically works like this. Once a community-based worker receives a referral from the Health Connect Hub, they engage the community member and conduct an initial intake, identifying risks and developing a care plan with clear outcomes for success also identified. They use the common data platform supported by the Department of Health for all documentation. And the data platform houses community health records, which are similar to electronic health records, but community-based. And those CHRs can hold consent, risk assessment, care plans, outcomes, as well as reporting and invoicing. So the CHWs work with community members in community to connect to resources to address the identified priorities related to physical health, behavioral health, and social needs. And they're also positioned well to respond to emergent crises like they did with the COVID pandemic, and hopefully not, but probably other future crises. The community hubs provide coordination to counter fragmented approaches to community health improvement. At Swatch, our Health Connect Hub has a strong network of partners and community-based workers that are engaging with community members who need support. The hub supports and networks over 120 community-based workers across our 3-county region. We have a contracted network of 18 partner agencies who employ community-based workers and also represent key sectors for whole person health outcomes. So partner agencies represent social services, including housing, physical health clinics, behavioral health clinics, and also EMS, fire and rescue. I do want to pause here to highlight the top priority role of community hubs in centering the community-based workforce and especially community health workers. Community health workers improve health outcomes. The evidence at a national level is conclusive. At Health Connect, we have many stories, but also independent evaluators and data scientists that have reported on improved outcomes, for example, in use of upstream ambulatory care or reduction of ED utilization when participants engage with Health Connect CHWs. Even though the COVID crisis, when access to services were trending in a very unhealthy direction, data from that time for Health Connect shows that there was increased access to appropriate services in the time of COVID when they had CHW support. This and other Health Connect data aligns with the broad body of evidence that continues to grow for CHW interventions. And I won't go on about it now, but a recent article from March 2023 in the journal Frontiers in Public Health does a great job of providing an overview of the value of CHWs. And I'll follow up with a link to that article in the Q&A section or send it to Nick to pass on to everyone. So I'll wrap up this introduction by highlighting that increasing equitable access and engagement to services is crucial to the role of hubs. We're proud that Health Connect has supported connection of over 5,000 people to community health worker supports. And crucially, we prioritize equitable access to care. We know that systemic racism is a public health crisis, and COVID has exacerbated health inequities, particularly for communities of color. The equity focus is fundamental. Community hubs center and support a diverse and trusted community-based workforce, so we are well positioned to support and connect with populations who have been historically and systematically marginalized. Health Connect has worked with agency partners to hire, train, and support a diverse cohort of culturally representative community-based workers to increase outreach, access, and engagement with communities of color and other priority populations. We know we're on a solid path of improvement for equitable outreach through Health Connect community engagement and partnerships when we look at data around Health Connect demographics as compared to census demographics. Our census data shows 80 to 90% of the population in Southwest Washington identifies as white alone. In comparison, first quarter data from Health Connect in 2023 shows that 41% of Health Connect enrolled participants receiving support represented a diverse continuum of cultures, races, languages, and communities who do not identify as white. We are seeing success in a diverse, trusted workforce connecting with and supporting populations that have experienced historical and systematic marginalization. While we're proud of our partnerships and ongoing work to expand equitable access to care, we recognize that there is deep need for continuous improvement in this area. Health equity remains a foundational priority of the work ahead. So with that, I'll wrap up. And I think it's going to be turned over to Allison. Thanks for the opportunity to be here today, and I look forward to our discussion.
Nick, you want me to just go?
Thank you so much, Eric. I think there's a lot of great information there, especially about these community hubs that I think could be a great resource if we're able to get more organizations connected. But yes, Allison, I think take it away.
Excellent, excellent. Well, it's great to be with everyone. I'm Allison Polson. I'm the Executive Director of Better Health Together. We serve 6 Eastern Washington counties plus the tribal reservations of the Spokane, Colville, and the Confederated Colville Tribe Reservation. We've been active in the ACH space, but prior to that, we actually were birthed to respond to the Affordable Care Act, and so have been doing community navigation from the outset. And so I'll just make a quick comment about community hubs, and that all of our ACH colleagues are in this journey of hubs. So there are hubs representing each region of the state, Better Health Together included. Eric was an awesome spokesperson for it. So I'm going to actually talk a little bit about some additional community work that has been funded through what we are affectionately now calling Medicaid Waiver 1.0, because our fingers are crossed that before too long, there will be a 2.0, further building out some infrastructure for the hubs. But in Waiver 1.0, our board allocated 10% of our total earnings. So our total earnings are projected to be at about 70 million. We're right on track for that. So 10% of that went into our community resilience fund. And we weren't quite sure how that was going to look at the beginning. And then COVID hit, the murder of George Floyd happened, and our board got super clear that that community resilience fund needed to specifically address the public health crisis of racism. And so that has really taken us on an amazing journey deep into the community. And as an ACH, we thought we were doing a pretty good job of like connecting, but as we offered, and we'll, at the end of all of this, I think we'll be close to $7 million invested into the community, specifically into Black and Brown and impacted community organizations. We found an even deeper network of trusted messengers. And so we have built out that body of work that is now starting to really connect in with our hub work. And what we found, so we were imagining this community resilience fund would fund lots of good work in general. But what we found is a real common approach of there being somebody in the organization that helps the community figure out how to access these resources. And sometimes it's literally like, this is how you get signed up for Medicaid. But a lot of times it's, this is a safe provider to go get your care from, or this is how we might tap into housing resources, food resources, et cetera. And so it's been really important, we think, to be focused on the development of this community-based workforce out in the community. We love what clinics are doing, hiring community health workers. The insurance plans have community health workers. We think there is really a special magic that's being created because of that trusted messenger connection folks have to community. So we're really excited about this network of folks, the opportunity with the hub infrastructure to really scale that up. It is completely worth noting that in many of these organizations, there's no paid staff to be those connectors. Those navigators are, you know, people feel comfortable with them because they're from their community. And so, you know, as we think about how do you not lose the organic, beautiful relationship part of this, but also, you know, we could be building a much more sustainable workforce for the community overall. So I'm going to pause there and just say, I think there's some awesome connection points that we should be thinking around workforce, around economic development, about wealth generation, about education that will blossom. And I think we'll see both short term and, again, just want to exclamation point some of the data that is coming out of the early hub in Swatch, but also a much longer term outcome that really gets us to some population health improvement.
Yeah, thank you so much, Allison. Wow, it's making me so excited about all of these opportunities for connection, opportunities to address upstream drivers of health outcomes, opportunities to engage with community. And it's just really exciting to see what's going on here. I think we have time for 1 to 2 questions, so I would encourage attendees to put questions in the Q&A box. But in the meantime, one of the questions that I have just broadly, I know we've been talking about trusted community members and trying to reach out and engage with communities where they're at. And I think that's a big barrier, especially when it comes to healthcare organizations trying to make referrals out to community organizations. So I'm wondering, do you have any best practices or lessons that you could share with other organizations about how to initiate some of these partnerships?
Allison, do you want to start with that?
I'm happy to take a stab. I think that it was really the top two or three things that would come to my mind is, one, it was really important that BHT, our board and our staff, had really grounded ourselves in good equity principles so that we actually looked like we could be a trustworthy organization to partner with. And that, I think probably everybody on this call is very familiar both with health disparities, but also the culture that exists often that does not make people feel safe to access care. So I think, making sure you've done your own work before you're seeking out those partnerships. And then secondly, I think, it was really valuable to invest dollars into these organizations first before we started saying, hey, you want to come be a community health worker in our hub? So that they had the capacity to actively participate.
I can tag team on that. I think one of the things that we saw as we worked on developing out hub partnerships, and early on in the hub, it was just about starting the hub, and we had some great initial partner agencies. And after about a year of data, we looked and we compared our census data with who we were supporting, and it was static. I mean, it was the same. So we saw real opportunities here. Okay, how do we really advance our health equity priorities in terms of our next step in terms of expansion? And our partnership opportunities from then on has required that partner agencies demonstrate capacity, commitment to connect, outreach, and engage and represent diverse communities, and be able to represent that in their application as we move forward towards partnership. And then really highlighting that as a key principle of the continuing work of improvement with them and with us and collectively. That's been a huge piece as we've supported agency partners to develop out and center and value a diverse community-based workforce that has informal and formal connections with oftentimes hardly reached populations or populations that have reason to be system adverse historically. And so that's been very effective. And the other piece that I'll say is that the hub's role, to echo Allison, to support the community-based workforce, not just our contracted partners, but broadly, that workforce development opportunity is really valuable. And professional development opportunities to bring folks together, to see one another, share learning, best practices, and recognize each other as resources, and really develop that shared identity as drivers for community health and change, is another opportunity for hubs. And we think that, that's maybe the most important opportunity.
Yeah, thanks, Allison and Eric. Jan, did you have any, learnings or best practices that you'd like to add here?
Yeah, just to share that we have kind of within our different projects with REACH and other funding, have been working on building capacity of organizations to work with community health workers. And what we have been hearing is that where they're trying to get more is not necessarily having folks refer people to clinics, but having the clinics refer people to community-based organizations. And so that's a lot of what I am hearing is, particularly in King County, there have been clinics that have adopted the community information exchange systems in order to be able to receive the referrals, but they're not using it to make the referrals as much as the community organizations would like. And then also just a community information exchange system doesn't supplant the need for the personal relationships. I've heard CHWs in the community say, well, you know, I'm going to pick up the phone and call so-and-so about this anyhow, because I know that they speak Vietnamese and that they work in that particular community. So why would I bother to, you know, if I'm already doing this call, why do I bother make this link through another system? So I think that that when we are looking at, you know, data and networks and kind of formal systems, we really need to understand how those overlay with the informal systems and the relationships that are already existing and the ones that we would like to help foment.
Yeah, thank you all so much. And I did notice that there were several other answers being asked and answered in the Q&A. And so I'd just like to highlight one answer that Allison gave in the Q&A, which is encouraging everyone to keep track of their local ACH, and I would add local public health jurisdictions. And so thank you all for being here today. I think we can learn a lot about how to engage with community and really use your organizations as resources as we're thinking about how to address some of these upstream drivers of health outcomes. So thank you all for being here today. And then as we look to close the event, I'd like to turn it over to my colleague at the Foundation, Emily Robson, who's going to share a little bit about what some of our next steps are for social need and health equity, and then some additional options for everyone to get involved in creating sustainable action. Thanks, Emily.
Yeah, hi everyone. My name is Emily Robson. I use she, her pronouns, and I'm the Transformation and Community Partnership Manager at the Foundation. And I'm excited to kind of briefly talk about our social need and health equity work and the implementation we're hoping to move forward with it, with all these reports that we've developed with your support. So firstly, as we discuss implementation, we want to first acknowledge what is known in implementation science as the no-do gap. And this gap recognizes the difficulty between what we know we need to practice and getting that knowledge actually implemented into what we actually practice. So we feel with these reports, our groups have started and supported identification of that no portion. But now we're hoping to work on, but how are we going to do that? Like, how are we going to get this into practice? So that's kind of what this next stage of this work is looking at. You can see on your screen, we have a diagram that kind of talks about our next implementation process and where we're moving. We did send out a survey in May asking for feedback from individuals who engaged within those work groups in our steering committee spaces. We completed an analysis of that survey, and I'll share some of those results momentarily. We are still planning to meet with our steering committee. We'd meet at the end of this month, and then starting in August, we will meet every month until the end of the year. We do have the opportunity, if anyone on this call would like to join that steering committee, please email us at brie@qualityhealth.org, and we can get you aligned to that meeting. We're welcome to expand that at this time. And then we're also hoping to implement this design from January 2024 and beyond. But you can kind of see with this yellow arrow, that's kind of where we're currently at. So with our survey, we again emailed it out to everybody who participated. We did find a little bit of a limitation of a lower response rate, possibly due to current capacity reasons, but we're hoping to overcome that limitation by further conversations with individuals like yourselves to provide feedback on what would be helpful from the BRIE Collaborative and the Foundation to support social need and health equity further within Washington State. But we were pleasantly surprised that we did get a diverse group of individuals representing different areas of the healthcare ecosystem. We asked some questions on members' experiences, and from it we could conclude people had a positive experience working in our work groups. We asked them about current barriers and facilitators they're experiencing for implementation that you can see on your screen here. We wanted to understand what they're experiencing and what is helping them overcome the different barriers they're experiencing. We also wanted to ask them within their current work in their organization, where are their own priority areas that they identified. And you can see 3 main areas that they happened to state on the survey. And we were fortunately able to conclude that they did align pretty well with the 4 brief reports that we've developed over the past couple of years. But this really led us to the question, so how do you translate the reports into action for the healthcare ecosystem? We provided multiple options of tools to support adoption and action of the reports into practice. And this question was developed to understand the next immediate steps for the steering committee could take to support implementation of the reports into practice. And you can see we provided them with quite a few different options, but from their responses, we identified the top answers as a learning collaborative, which we've heard through our different speakers today, that they have them within their own organizations and communities, but learning collaboratives really raised to the top of areas individuals wanted to engage further in. Additionally, implementation collaboratives, implementation guide, the development of metrics, patient education materials, and workflow tools. So those are some areas we'll look into for the immediate next steps. But we also saw and asked questions about future long-term work. What would they like to see? And we asked them both 2 types of questions. So which of the following, when we gave them some options, would support further action to address social need and health equity within Washington state? And they identified the answers you could see below. And then we asked them what their capacity was. So we were able to see both what they feel is needed and what their capacity is, which led us to figure out 4 main areas that will move forward within our steering committee to kind of see what would be great to develop. And you can see those as learning collaborative, action collaborative, strategic planning, and quality improvement collaboratives. So again, our next steps are, if you want to join the steering committee, please email us. It would be lovely to connect with you all further. You can also sign up for our alert listserv with the BRIE Collaborative to learn more up-to-date information on these reports. And we hope that you take the time to read the full reports once we release them later this summer. I'll pass it off to Nick.
Yeah, thanks so much, Emily. So I think there are some clear next steps here for us at the foundation. And I hope today, as we've gone through our presentations and learned from other organizations around Washington, we've really seen the need for shared accountability and collaborative action. We've tried to talk from multiple different sectors about what we can all be doing to integrate social need and health equity into the regular delivery of healthcare services. And I hope we'll be able to continue to work on this in the future. I do want to give one final thank you to all of our panelists and all of our speakers for being willing to share what they're doing with us, and to all of you, to all of our participants for attending today and engaging with this conversation on social need and health equity. I think, as we've seen, there are many barriers to getting this work off the ground, but when we do have a coalition of willing and engaged members like ourselves and all of your organizations, I think we really have the opportunity to make a huge difference in the health and well-being of Washingtonians. So thank you all for being here today, and thank you for bearing with us as we end about a minute late. But I hope that everybody is able to take what they've learned today and bring it back to your organizations. With that, I will close, and then just a final comment.